भेजू क्या किसी को? यहीं खड़ी रही, तू मेरे पास आगे आ जा। रेडी नहीं हुआ है, चेकआउट करना था ना। इसके बाद प्लीज सर स्टार्ट। A very good morning, everyone. Warm greetings. Today is the last day of the second World Dental and Facial Aesthetic Conference. Today we have lectures followed by valedictory function. Also, we will announce the result of scientific presentation. Now we are continue with the lectures. For the first lecture of today, I would like to invite Dr. Afzal Ali sir. He is the professor at Department of Conservative Dentistry and Endodontics in Pacific Dental College and Hospital. Topic for this session is Unblock the Pathways with Static Guides. Over to you, sir. Please come up on the stage.
Good morning, everyone. Now I can hear you. First of all, I would like to thank the organizing committee, CynoDent and Pacific Dental College for organizing and for giving me this platform. I will be talking about lights. I will be talking about the calcified canals and its management. Actually, this is the most oftenly we encounter this challenge while managing the cases, routine endodontic practice. Majority of the time we have found this problem with the posterior teeth, most oftenly molars, but this could be managed because over there the calcification will not be that much prominent. Only they will be at the apical third or coronal obstructions will be there, but once it is negotiated or canal is found, then the further path can be continued. But however, this thing, if you talk about the anterior teeth, it is problematic. We will not be able to manage these cases until unless we use certain magnifications in our practice, or loops or direct dental operating microscope. So with that, we often get a good result, but again, it matters with the clinical expertise of the person. Okay, so it's not easy job for everyone to conduct to do a good treatment, especially Now have a look at this CBCT picture. Click once. You can see over here that there is some amount of calcification. There is a calcified tooth central incisor, and in the lateral incisor you can find that there is some bulge-like structure, additional bulge-like structure. So actually this is the case of calcified canals, and the additional to lateral incisor is having a bulge-like structure which is called as type 1 or 2 dense invaginatus based on extent to the level of or beyond the CEJ. So this tooth, when we run the CBCT, we found that the canal is patent only at the apical third, but the coronal part is totally calcified, which is often difficult to manage, and there are chances that we may end up into complications or tooth sacrifice or weakening of the tooth, gorging. All those things can happen. This is a lateral incisor where you can see there is a fan-like projections over the palatal aspect. Now again, this is a challenge to a clinician while performing the management. So this is additional root type 3B dense invaginatus case. Next. One more lower incisor, type 3B dense invaginatus case. Again, this is also a clinical challenge for the endodontist or for even for the clinicians, general clinicians also. Majority of the time, teeth with such a findings are often indicated for extraction. If you see the literature, Journal of Endodontics and International Endodontic Journal, majority of the time it will be said that traditionally these teeth are subjected to extraction if they are symptomatic. Now, tooth with the canal calcification, most oftenly there will be a history of trauma in the childhood. Why? Because anterior teeth are more proclined, okay, more subjected to the external environment, and during the childhood period, definitely there will be the incidence of fall. So most oftenly, because of it, 10 to 12 years or 15 years age group are often subjected to a trauma, hit, blow, fall, or any other accidents. In those cases, if it is managed by antibiotic painkiller prophylactically, or if it is not managed, then these teeth will remain in a dormant stage for a while. Maybe 5 years, 10 years, 20 years, 30 years, but ultimately they will develop the symptoms. The symptoms can be in the form of a large periapical lesion. The symptoms can be in the form of a rarefaction or pedial whitening, as you can see over here. Now this is a unique case. This is the case of lower premolar 4-4, where you can see there is a periapical changes. The tooth was severe tender on percussion. There is a history of prolonged orthodontic treatment. So even orthodontic treatment, prolonged orthodontic treatment, or inadvertent force application can also lead to canal calcification. Now here you can see that there is a pedial whitening and periapical changes. The tooth is totally calcified. The tooth is managed with a non-guided approach. I'll tell the protocol to be used, but have a look. These tooth will be symptomatic. Majority of the time, we should go for the treatment when they develop the symptoms, because it is like hanging yourself. Okay. So you will invite trouble for yourself by attending such a teeth. So if you have a courage, then you attend it. Otherwise, you should leave it for the time when they develop the symptoms. There is a general consensus that the root canal treatment is not indicated unless there is a clinical and radiographic evidence of pulp and periapical pathosis. Till that time, do not touch these teeth. But 100% those teeth which are asymptomatic right now, in the future will be symptomatic. Now, at what time, I don't know. It may be 5 years, it may be 10 years, it may be 5 months. But definitely those teeth will be symptomatic at some point of time. American Association of Endodontics classified the cases with the canal calcification under the category of high level of difficulty. Now, what do you say rest all are my cases. What do you say? Root canal treatment is done. Some apically it is short. Okay. It is very good treatment. The gutta percha is coming out from the labial aspect. It has perforated the labial cortical plate, the labially, the tooth structure, and even the cortical plate. And the gutta percha may be somewhere in the gingival sulcus area, or might have protruded out. Now this case has been managed as shown as given in the Journal of Endodontics. But while managing the cases with calcified canals, usually we prefer to use the long neck burrs or GD drills. The GD drills are a tool. We can use it if we do not have any the contemporary instruments. But these devices are also problematic because they tend to create the bottleneck appearance, gouging, excessive tooth structure loss. So we should be careful even about that also while using them. Does all the cases of calcified canal can be managed by you or by me? Does I encountered any failure? Yes, I have encountered the failures. These are the failures. 2 cases are mine, where you can see this. The first radiograph is of the degree of tooth structure. This is managed successfully, but the amount of tooth structure being lost. I will show you some more radiographs even where the tooth structure might have lost till below, even up to CEJ or below CEJ also. This is the failed case. You can see a file fractured over here. It was not managed. We tried a lot but could not manage. This case was managed. You can see lower incisor, but there is an excessive tooth structure loss. The canal is somewhere over here. But however, this case is managed. Now, this is the case, central incisor. The working length is determined. What do you say? Is it proper? By looking at this radiograph, you may say that this is proper. But no. When I placed the gutta percha was folding at the apical third. Means there was an apical third perforation. The gutta percha was coming out somewhere labially or palatally at this region. So the folding of gutta percha while compaction, I came to know that yes, I have perforated in the apical third. So post PG, this was my first case, and then I did the root and resection and filling. As you can see over here, the root was resected and this part was filled with an MDA, and the person is fine. Calcified canals. This I have shown you even previously, the radiograph. Now you can see the amount of tooth structure loss just to find the canal in this case. The tooth was symptomatic, there was pedial widening, there are 2 teeth, but always try to do one at a time. Don't jump all together. The same case, I was able to manage it, but see the amount of tooth structure which is lost. So by sacrificing the tooth structure, I got the canal. But one thing is there is a weakening of the tooth, the strength of the tooth is lowered, the fracture resistance of the tooth is lowered, so this may not last longer. But however, prosthetic rehabilitation will be done, then yes, definitely it will function properly. Now, as per the Wales experiment, there is a finding that the MOD cavity preparation results into the loss cuspal stiffness by 63%. So when we do the access cavity preparation, definitely we are creating a tooth structure loss. Also, by canal shaping, I am also removing amount of dentin over there. So definitely the tooth are weak, and also these tooth will be non-vital, means in the future, so there will be dehydration and the stiffness of the tooth will be lowered as compared to the previous what it was. So during the access cavity preparation, we can follow certain protocols as to reduce the amount of tooth structure loss, like constricted access cavity preparation, where the canals will be negotiated and a part of a soffit will be preserved, the pulpal horns will be preserved, so that a stiffness amount of tooth structure can be saved. And also this is critical area, the neck of the tooth, pericervical dentin, 4 mm above and below the alveolar crestal bone. It is critical zone. This need to be stronger. So the tooth structure should be adequate over this part. The regular armamentarium which we prefer, this is the regular armamentarium. So there is no, even in routine endodontics we do use them, but the only difference is these two burrs. This is for the crown removal purpose. So long neck burrs, these are more often used for the calcified canal management, especially anteriors. Now all the cases can be managed by guided or non-guided approach, but I'll show you majority of the cases are done by non-guided approach because of patient feasibility. If there is a feasibility, definitely we can go ahead with the guided approach, but sometimes we have to go with a non-guided approach for their management. This is a calcified canal case. I have shown you previously the OCBCT. Now this case is managed. Additionally, I told you that there is a dense invaginatus, so this part is managed. Prophylactically, I did the sealing of it. Sir, why you did the sealing of it? The reason being because dense invaginatus will be having grooves, fissures, which more oftenly lead to the invasion of the bacterial growth over that part, and the tooth may become involved with pulpal involvement, may show the pulpal involvement in the future, or periapical lesion. Guided endodontics. So here I will discuss one case and then I will show the subsequent cases. Now here this guided endodontics actually it is taken from the implantology. So for the implant placement they were using this approach, using the guides were designed and the drills were positioned over there, over the guides, so that they will be able to achieve a proper drilling and the implant can be placed at the proper position without damaging the anatomical sites. Here, from them, we have taken it into endodontics. Now it can be used for the conservative access cavity preparation. It can be used for canal calcification, missed canal finding, dental anomalies, endodontic surgery, autotransplantation. So it's up to us. We have to think about it where else I can use this technology. I'll show you some literature where they have been used in myriads of approaches. Now for the guided endodontics, especially static guided endodontics, I prefer this approach. There is one more approach, dynamic approach. Dynamic navigation is costly. The cost of the device is 45 lakhs. And per patient you have to pay something minimum $50 to $100 to the company for the subscription for particular case, one case at a time. So that is costly. So there need to be a huge investment for that purpose. CBCT is mandatory for navigation, dynamic or static navigation in both the cases. Now this is dynamic navigation. You can see that this is the machine. There will be cameras fitted over there. There will be trackers. Tracker will be placed whichever the jaw you are doing. One tracker will be over the jaw. Suppose mandibular jaw, then if you are performing any procedure, then it will be on mandibular jaw. The other will be in your handpiece. And this will be tracked over here. There will be a live screen and you will be focusing your eye over there, over the bull's eye. And this is the depth which you have to, desired depth which you have to reach. This is the penetration which is being achieved, and how much is left out they will tell you. You have to keep your drill over the bull's eye. It should not deviate anywhere. If it is deviating, it means that you may cause for the static guided endodontics. What all do we require? We require first digitizing the bone root and neuromuscular spaces. So for that purpose, CBCT I need mandatorily for the case. So first CBCT will be taken off of patient. Then what do I have to do? I have to digitize the tooth surfaces and soft tissue. So for that purpose, most commonly intraoral scanner will be used. However, there are other approaches. I don't want to discuss that. The third part will be the creating the construction or the virtual model creation. So that will be done with the software you have to do. There are various softwares available, free or paid. And the last step is the fabrication. The STL file which will be generated in the third stage will be sent to the printer, and the printer will do printing and you will get the guide. CBCT now here we are using. So there is a clear guidelines by the American Association of Endodontics and the ESE, European Society of Endodontology to be followed. These are to be used in cases with high difficulty index. The main drawback is they are ionizing radiation, so we cannot take the multiple shots. Also, the FOV should be limited for such cases, especially for the calcified canals, and the unnecessary exposure should be avoided. Now, software work will be like this. What you can see, some lines, white lines, these are nothing but the superimposing of the impression or the STL soft tissue files. Then you will place a tube and the sleeve will be positioned, and this will be the virtual guide which is created. Now this is the STL file. You will send this file for the printing purpose, and then you will get the guides. The schematic representation I would like to show here: pulp canal obliteration, periapical lesion. Now the guide is supported over the tooth structure. The drills were placed through this hole, through this sleeve, and the drill should be long enough to reach till the apical third. So this is the limitation. Especially in India, we do not get such drills. So if we use the implant drills, then definitely the amount of tooth structure loss will be more. We need some precise drill. There are precise drill available, but again I am saying the length is the limitation. The length of central incisor will be usually 25 mm. Usually, the sleeve part, this part should be at least 3 mm in height for it, for the resin component, so that it will be strong enough. So there will be 28 mm. So at least 28 mm or 30 mm drill should be there available in the market, so that you can use. Endoguide burrs, various burrs are there, but again the limitation is at the shaft end. The 32 mm GG drill is also available, but again I am sure enough that only 16 to 17 or 18 mm you will be able to reach into it from here. So you can minus 3 mm part. So 15 mm only you can reach over there, because the remaining part will be in the head part, or will be the part which is fixed over the ledge attachment. So let's see some clinical cases. Calcified canal management. Now this is the 442 history of prolonged orthodontic treatment. The person gives history. The lady is giving history of 4 years orthodontic treatment. The tooth was severe tender or percussion. She was not allowing me to touch the tooth even with the finger. Periapical lesion and canal calcification. Some may say that this is a mental foramen. Okay, we will see in CBCT other images. When I saw the other images, I found that the mental foramen is separate, and this periapical pathosis is also there near to the root of 4-4. As you can see over here, periapical pathosis, the canal calcification, and apical 1/3, there is a patent canal. Virtual drilling plan was made. The guide is fabricated. Drilling is done through the guide, and working length is established, and then regular endodontic procedure is followed. Again, one more case of calcified canal. You can see there is a fracture, discoloration of the central incisor. When I took the CBCT, I found something different. Periapical pathosis, shifting of the root, back. Shifting of the root, periapical pathosis, open episis, central incisor, lateral and central incisor with the calcified canal. So there are 4 teeth to be managed over here. Periapical pathosis even in the lateral incisor, periapical pathosis in the central and lateral incisor over here. Over here you can see that the adjacent central incisor is also there. The guide fit is checked, and with the slow speed burr, long neck burr attached to the slow speed micromotor, the drilling is done. First the punch cut will be made, and then the further drilling will be continued. So here are the follow-up radiographs intraoperatively. As you can see over here, central incisor, this tooth is done with a routine endodontic. This tooth and the central and again one more lateral incisor over that side, all are managed with a guided endodontic approach. The amount of tooth structure loss is minimal, but one error is encountered while doing so. You can see over here file separation during initial negotiation time. However, this Now, this radiograph again is taken from journal. So you can see there is a dense invaginatus. Now, why these teeth are problematic? Because I'm told there will be a groove present, and the groove is susceptible for growth of bacteria and penetration, and this will often be communicating with the pulp. So that's why these teeth will show symptoms or periapical pathosis in the future. Type 1, 2, 3 of Kohler's classification up to CJ, below CJ, and if it is opening at the laterally or at the pulpal at the canal orifices, then they are classified as type 3A and B. Now this is one more case. You can see two central incisors. One is discolored, other is fractured. Okay, this is the radiograph. You can see there is something anomalous. Again, one more case of dense invaginatus. There is a lesion, central incisor. There is a lateral lesion over here. The two lateral incisors are having some peculiar feature. This is called as dense invaginatus. Now, I planned the prophylactic sealing of dense invaginatus for the lateral incisor and the routine endodontic for the two central incisors. Why two? Because this is guided approach. The laterals were managed. Next, laterals managed. Laterals are managed with a guided approach. Both the treatment were done. MTA was filled, and the glass ionomer or composite resin can be filled over the prepared site. But the two central incisors, they need the treatment. The two one seems to be normal, but in the CBCT, there was a periapical pathosis and it was communicating to the nasal floor. So there was symptoms to the tooth, adjacent tooth also. Radiographically there are findings, so that's why we perform both the treatment, MTA apical plug followed by the backfilling with a thermoplasticized bit aperture. Next. A rare case of multiple dense invaginatus, published case. There are two dense invaginatus over here. This is published in RDE, Restorative Dentistry and Endodontics. The guide was designed. The first virtual plan, then guide was fabricated, and the laterals, the 1-2 is managed and 2-2 is also managed. For the 2-2, you can see that there are two dense invaginatus, double dense invaginatus. One is superficial, other is deep. So both the parts were managed, and the central canal is also, main canal is also managed because there was a periapical pathosis. So this is the path. You can see all the paths are different. They are not in the same path. So that's why by doing so I am able to save the amount of tooth structure. So this is the follow-up radiograph. Everything was fine. Post-operatively. Next. One more application of guided endodontics in for gaining access to the prosthetic through the prosthetic crown. Now, majority of the time, what happens? We don't know the angulation of a tooth below the crown, especially the FPD patient. Wait. Back. We don't know. So most often we try to palpate the bone, cortical bone, and try to find the angulation of the tooth, and usual location we try to do it, or we try to do the probing over that aspect in order to find back. First two picture to find the angulation of the tooth, because majority of the time we land up into perforating the crown and we will be somewhere else. Also, we don't know how much amount of tooth structure is there below the crown. The crown may be cut aggressively, the crown may be cut minimally. Both the possibilities are there. So better, and also this is a calcified tooth at the apical third. So I tried to do it with the guided approach. When the guide was done, it was found that it is having certain tilt. It is not straight to the crown part, the prosthetic crown part. So it is having some certain amount of tilt. So it is confirming, yes, the crown below, the tooth structure below this is tilted. It is not straight. The guide is fabricated, access was gained, placed, access was gained, and then canal through the guide, the canals were located, and then observation completed. One more approach, effectiveness of this static guided endodontics, we checked it on the failed regenerative endodontic cases in vitro. So here, through the MTA, we try to find out that how much of the tooth structure will be lost if we do it with a guided approach, and what will be the stiffness of this tooth. So these were when we were gaining access through the MTA, the amount of tooth structure loss were this much. Whereas in cases of guided approach, you can see that the MTA is present, it is not a problem if it is present also. But at least I am able to get the access to the apical third. So that is more important. So we can manage this case with the minimal tooth structure loss, even in failed cases of regenerative endodontics. Next. So to conclude, first is the first thing is armamentarium is expensive, but as compared to the routine endodontics, but not that much expensive as compared to the guided the dynamic navigation, where you need less of rupees. You need an advanced lab support. You need the some data to be shared with the lab, the prosthodontist, or you should train yourself in the software manipulation and the virtual guide design. The second thing is number of appointments over here will be increased. But please remember the intraoperative time. The intraoperative time will be less over here. Whatever the planning you have to do, you can do it at your home. You may do some training over there, and you may find out that how much, what will be the angulations and all. But at least when the patient is sitting on your chair, at that time the amount of time consumed will be less. The other drawback of this is radiation hazards. It will be there if you do it even with the dynamic navigation. CBCT is needed. Sometimes now, majority of the cases, usually to gain the straight line access, we do the incisal cutting. So aesthetic will be compromised in these cases. However, with the restorative application, we can manage it, but still there will be some thin enamel part may be visible over there, and posteriorly it has limitation. The interocclusal space needed should be more in order to do these cases. Posteriorly we don't get that much, so it is quite, however the cases are being published, but still we have the limitation in this. Some cases other guided endodontic approach used in for gaining access through the fiber post published. Next. Guided endodontic in management of integrating the molars with the guide, intracoronal guide fabrication. They have found that molars can be treated even with the guided endodontic approach. Now this is the comparison between the amount of tooth structure loss. Again, it's a 3D printed model. So canal location, you can see conventional 41% can be cases were managed. Mean substance loss is almost 95%. Treatment time consumed is 21 minutes, whereas in guided endodontic approach the time taken is 11 minutes. Amount of tooth structure loss, you can see that it's 95%, MMQ 9.8, and the canal location was done in 91% of cases. So definitely guided endodontic approach can be used. It is less invasive, more safer, but clinical expertise is needed. The pre-operative planning should be done. Intraoperatively, the time consumed will be less definitely, and most oftenly, the cost will be higher as compared to the regular endodontic approach. Endodontic treatment in cases of dentin dysplasia. Now this will be totally calcified. This is double dense invaginatus, multiple published case which I have shown you. Pulp canal obliteration using the static guides. Type 2 dense invaginatus, I have shown you this also. Accuracy of the dynamic navigation we have checked, and it is found that it is promising. The results are good, but there are some inherent drawback. Cost, the major drawback associated with it. Thanks a lot. Thank you very much.
Thank you, sir. It was a wonderful session. Now I would like to invite Dr. Preet Jain, sir. He is the Vice Principal of RR Dental College and Hospital, Udaipur. Topic for this session is When Beauty Fades, Understanding and Managing Implant Aesthetic Complication. I request you, sir, please come upon and start the session.
Nice presentation. Thank you. We have oh yeah. I have. Sorry, come again. Yeah, there's no audio for me. Yeah. Yes, guys. Before I start, I would just like all of you to listen to me. And I just want that everybody should participate with me. So everybody is ready to do that? Yes. Okay. So before we go further into the kind of very superficial approach to implant aesthetics, how many of you are aware of dental implants per se? Wonderful. So few people who are not, so just be with me, try to understand, and if you can, if you have anything for me to tell, I would be happy to tell. Okay. So how many of you know about aesthetics per se? Aesthetics. Okay. Do you agree that there is a difference between aesthetics and cosmetics?
Yes.
So this will be more of a two-way traffic, as I say to most of my lectures. So would you be able to participate with me? Yeah. So if I ask you about aesthetics, एक light on रहने दो ना उनका side पर please, so that वो सो नहीं पाएंगे ना? Yes. So if let me ask you if somebody can stand up and say the difference between aesthetics and cosmetic, I would be more than happy to listen. Anyone who would like to try? Cosmetics, aesthetics, anyone? So, okay, just for you to know, basically, never mind, don't feel so fearful of things. So, aesthetics is basically going more towards natural side of the patient, or what we are trying to create whatever the patient gives us. Cosmetics is more of using chemicals and different kind of substances to make the patient more and more beautiful. But having said that, today we are specifically focusing on implant aesthetics, where generally we can go wrong, and we are not going much into the details of how aesthetics are done and things like that. Only thing is we will be focusing on the aesthetic zone, which will be the maxilla, preferably maxillary anterior region as well as mandibular anterior region. We will just discuss the basic principles of them, what all things can go wrong, where all things can go wrong, what things can be improved from your side, what all things to observe. Observe when you are rehabilitating a patient with an implant in the anterior or aesthetic zone. So here, aesthetic zone, at least you are clear with that, what is the aesthetic zone of a patient? Come on guys, help me out. Are you clear about what is an aesthetic zone of the patient? Okay, so what we are going to discuss is, we talk about a lot of things that we are going to do this or that. Yes please. Am I audible? Am I audible?
Yes, sir.
If that's okay. As long as you want me to be really loud. I'm fine with it? Okay. Yes. So, now guys, what we are looking here is, and what we are looking in this entire session is, basically some idea regarding to the various aspects of aesthetics in the aesthetic zone. I am going to talk very less about the external aesthetic features, but I will be talking about, yes. Oh, okay. Oh, there's a live session also. Sorry about that. Yeah. Can you? Hello. Okay. Yes. Can you, somebody, Ankit, can you please put it? Thank you. Hold on. Check. I'll just keep things here, okay? No confusions. Yes, guys. My voice is audible now? Loud and clear? Okay. So as I was telling you, what we are looking here is basically, we are looking here into the details of aesthetics pertaining to implants, okay? You might have been some idea about aesthetics in your conservative, in your prosthodontics and things like that, but here we are specifically talking about implants. And for that, let's start our session and understand where this word comes from. So, har samay it is necessary we have to start, and this start comes from basically Greek. So, Greek said the word aesthetikos or aesthetikos, okay? So, it is that origin of word which literally in Greek meant perceptive, sensitive, pertaining to sensory perception. Okay, I would like you to just understand this and note this, what we want. So basically it was aesthetikos. Aesthetikos said that it basically means a perceptive, sensitive and pertaining, it is basically pertaining to sensory perception. What it basically meant was, it has emphasis, it emphasizes on the harmony of teeth, the facial features, the gingival health as well as the alignment of the tooth. So the branch of aesthetics basically, it comes into the natural and beautiful smiles where we need science as well as the artistry in us calibrated, calculated and worked out so that we can give the patient the best possible outcome in dentistry as well as in implant dentistry as well. So about aesthetics, where it all started. So where it all started was, you may not know, I will just add to it. There was a success criteria of implants, guys, which was Albrechtsen in 1986 with Lechholm and Brandmark. He laid down some criteria for aesthetics, and in that you can see that 1986 was the year when the implant success criteria were laid down. But they categorically forgot the aesthetic mention in that. They basically were focused on bone and associated bone and bone loss and things like that. So there comes Smith and Saab in 1989, where basically they did introduce aesthetics as one of the success criteria for implants. Then what happens next? We have 1986, where it was mentioned that bone loss was also responsible for losing of aesthetics in the patient. Then again, Lechholm and Zarbin, basically when they started talking about the bone, they never mentioned they never mentioned about the aesthetics per se. But then later on, as the time progressed, Gent came into picture, and he suggested one of the very early classifications of your interdental papilla, where he spoke about something called pink aesthetics. So we are going to discuss a little bit in detail about pink aesthetics as well. And then later on, as the science improved, as the art improved, the scientists came on and said that yes, it is very much necessary. We can have subjective evaluation of aesthetics by subjective. आपको पता है subjective और objective में क्या difference है? Please, can you tell me? Yes, yes, please. Yeah, go ahead, please. Okay, that's very interesting. So please sit down. If I may put it in more simpler way, subjective is basically what you feel is aesthetically looking good. What you feel, or what you feel. But objective is something which we can quantify. You know, quantify? Like, how long is this lamp? So you can say say it is long, but long means what? If I give him a number, let's say it is 3 feet long. So what is going to happen? I will tell you the exact quantity, what is very much available here. Is that understood? So subjective and objective are these two different things. So from here, the story still goes on, story is still evolving. There are so many things which have come into the picture. These days they have come into the phase of digital dentistry and things like that. So anyways, so today what we are going to briefly discuss, again when I say briefly, I am going to be very, very brief, guys. If I go anywhere longer, raise up your hand and you say, yes, sir, you are going too long, please stop. Okay? So now, we are going to decide on aesthetics. We are going to basically talk about how we do the patient selection, very briefly, what will be the smile line per se, how the soft tissue affected, how the hard tissue affected, then how the implant placement, the position, the location of the implant is going to affect it, and then finally what are the different types of prosthetic biomaterials which have better aesthetics or less aesthetics or whatever. Okay? Yes. So, smile line, everybody is aware? What is smile line? Come on guys, be with me. Are you there with me on smile lines? For the people who don't know, okay, out of this, which one you feel is better? This one? Okay, why do you say so? Anyone? Very nice, very nice. Go ahead. Yes, ma'am. Excellent. So we can see here that this is low lip line, this is high lip line, and some people call it moderate or some people call it normal lip line, where the smile or the incisor edges of the anterior teeth follow the inner vermilion border of the lower lip as per its curvature. Is that understood? So we have three types of smile line. When the patient comes to us, it is very important for us to talk to him, and once you talk, there will be certain conversations which will make him happy, which will make him smile. So your job as a dentist is to observe what you are doing and how you are doing it and what about it. Okay? Then people said about, okay, foreigner specifically, that okay, the references are here, guys, you can note down if you want to, but just to understand, pink and white aesthetics. What do you mean by pink and what do you mean by white? Can anybody tell me? Yes, right. So pink, we don't have pink, we are Indians, please understand. We are brown people. So we may not have exactly pink color gingiva, but at the same time, the general or terminologies, this has come from West. So these West people, they always mention pink because this is their normal color of the gingiva. So pink and white, white is of course the teeth, what we are talking about here. So we have different types of pink and white aesthetics. I am not going into details now, we are going to go into details now. So yes, first, pink aesthetics, okay. It has come too fast, otherwise I would have asked you. So what you have to understand is, go to point number one. What is point number one? Point number one is mesial papilla. Is that clear? Which you have to look into the patient. Boys and girls, are you able to hear me? And are you able to hear me properly? Yes, wonderful. So what we are going to do here is, this is mesial papilla, this is distal papilla. Now imagine if this mesial papilla goes in for a toss and reduces up to where the 4 is. You know how it is going to look? It is going to look black space which will be created there. Yes, and that will look aesthetically very, very, very unpleasing. Is that understood? So then, what is the two part? The two part is the distal papilla. So we spoke earlier when we talk about GEMT in 1997. What we spoke about is basically this papillary film. So when the tooth is not there and we are planning for implant, we have to see the height of mesial and distal papilla, which will be indirectly or directly related to the bone which is present there. Is that understood, boys and girls? Yes. Then what we have here is, we have 3, 4, 5, 6, 7. So basically we will go to this. This is called as the deepest point in the marginal gingiva, also known as the zenith. Okay. Then we have, of course, the contour of the soft tissue. We know that contour, color and texture they all will be altered when gingival health is not proper. Is that clear? When gingival health is either suffering from inflammation or any kind of infection, this is going to directly affect the contour as well as the other aspects what we spoke about. Then of course there is an important part about the alveolar bone beneath the gingiva. So alveolar bone, we will talk details in the heart tissues, but here if the alveolar bone is not sufficient, overall picture of your respective patient is going to be very, very grim, and many of the times you need bone augmentation in order to create the right amount of bone for that particular patient. Is that understood? Yeah? Now, so let's go further. Okay, now there is something called gingival biotype, guys. Gingival biotype is nothing but, what do we have here? Gingival biotype. Can anybody tell me what is gingival biotype? Anyone? No? Okay. So for all of you who are present here, gingival biotype is directly nothing but thickness of the gingiva draping the tooth. Thickness. Okay? Gingival biotype is nothing but thickness of gingiva draping around the tooth. So here, can you tell me 1 and can you tell me 2? Can you tell me the difference? I said gingival biotype is the thickness around the tooth. Can you tell me what exactly is 1 and what exactly or A or what is B? Yes, I need your inputs. Yes, please. But a little faster because they have given me 30 minutes. So I don't want to, rush very soon also. Somebody, yes, yes ma'am. Could you please?
In the first picture, the
Yeah.
gingival biotype, that is the thickness around the tooth is less.
Very nice. Please sit down. Very good. So what we are talking about here is basically thickness of your soft tissue. The thickness has to be either it has to be thin or it has to be thick. Okay, by default. That means either it is going to be 1 mm or more than 1 mm or less than 1 mm. Okay. So here we can see that this is very much transparent. So this is a thin gingival biotype, and this is a thick gingival biotype by default by the measurement of the gingiva. But at the same time, guys, how it is useful in implant? So it is useful where when we have this type of gingiva, the body and the shoulder of the implant must be placed more parallel. Is that understood? If it is thick, then as planned, the gingiva or implant planning what we have done, it is going to be placed as it is. Is it clear? Yeah. So we go ahead further and understand. Then we have the papillary relation. So as I told you, we have a mesial papilla and a distal papilla, guys. What is important for us as far as the implantology is concerned is the mesial and distal papilla, when measured from the crestal bone, should be at least 5 mm. Is that understood? If it is going to be more, then we will have bit of problem by shifting of the papilla. If it is going to be less, it is always beneficial. Is that understood? It should not be more than 5 millimeters. Then other procedures we have to think about, or other line of treatment for placing the implant has to be thought about. Is that clear? So this is quite important for you. If it is at this, definitely the proximal health of the implant is going to be really, really easy to maintain and done it well. Then as we spoke about, you can see here that we have a gingiva which is healthy, and we have a gingiva which contains basically the plaque and thereby involving gingival inflammation, which further proceeds to degradation of bone. Okay, so what we have here and what we have to understand here is, no matter what, if the patient is not maintaining the health of the oral cavity, he is not a suitable patient for implants. Please understand that. I am making a big statement, but you have to understand this very, very clearly. just because patient is able to pay you, okay, find some bucks, please do not convince the patient unless he is ready to keep his oral cavity fit and fine, that is healthy. Is that understood? Yeah? So, this is what we have to understand. Now, as I told you, in the alveolar process deficiency, we spoke about the bone which is deficient, the graft which has to be there, and later on only we can produce the implant in order to have the proper aesthetics. Now, for you to understand what happens when we have the teeth with the bone right now is you have a bone which is healthy, you have teeth which are supporting the lip. The moment the tooth is gone, what happens there is a loss of bone in the form of residual ridge resorption. So that leads to decrease in bone width as well as bone height. So the moment there is a decrease in bone height and bone width, there will be definite loss of support of the lip and your smile degrades accordingly. So beautiful smile is going to change when you are going to see the loss of the tooth. Okay, so that is why this alveolar process deficiency should very credibly be dealt with. Has it to be always a graft? No, not always. But when there is a severe deficiency, we definitely have to go ahead with the grafts and then go about it. So here, as I told you, we are talking about zenith. Okay, last, is it clear where the points are? Yes? So deepest point in the central, lateral and the canine. So all the three have different levels. Please understand. Yeah? So how does it look? Does it look aesthetically pleasing? It looks one tooth is longer than the other. Yeah? So which is not going to, so nature has always created a balance. So this balance has always to be maintained as far as the treatment, be it your prosthetic treatment, be it your implantology treatment or be it your restorative treatment. That has to be maintained. Then you can see here, these are the zenith points in the natural tooth, and accordingly these are the zenith point in the implants as well. So you can see the level of the zenith point where the crown is going to get the curvature, and you can see where the implant has to be put. You can see the abutment here. Now, from that pink aesthetics, let us shift our focus to white aesthetics. Now, when we talk about white aesthetics, guys, there are different aspects which has to be seen, like the position of the tooth, inclination of the tooth, midline if at all, incisor lengths. Incisor lengths should not be very longer, it will give very unaesthetic, as we saw earlier, very unaesthetic. The dimensions of the tooth, zenith points we have already discussed, the embrasures, and of course symmetry and balance. Okay, so there you have to tell me now that this is a tooth which is embedded into the bone. You can very well see that there is a palatal bone, there is a labial cortical bone. Is that understood? So in most of the cases in the anterior region, you can always get very less amount of labial bone as compared to palatal bone. So many of the times, if you have not done your radiographs properly, dentists, out of their enthusiasm to place implants, they go in such a direction that they make this bone very, very thin, or they completely denude the bone of the architecture. Okay, so here on the other side you can see all the areas of the white aesthetics, including two more, but I have not mentioned. Let's not discuss too much in detail. Let's go with very specific things. Okay, so 1, 2, 3, 4, 5, you can see the translucency, you can see the color, you can see the neck portion, you can see the zenith, you can see the overall picture of the tooth. So this is the frontal profile, this is the lateral profile as well. Okay, now what do you say? How is the smile? You like the smile? Okay, I am not able to hear you. Is the smile good?
Yes, sir.
Okay. How about this? Sorry? see this smile, there is a gross asymmetry of the face. So once there is a gross asymmetry of the natural midline of the face, once that is there, we always have the kind of imbalance. When the imbalance occurs, there is a definite amount of anesthetic pleasing, which is not so pleasant to the patient as well as to the doctors or to standbys. Now, when we talk about the placement of the tooth, there is one more important factor as the mesodistal dimensions of the tooth. So, mesodistal dimensions of the tooth are important because if you increase them, it will encroach the distal and the mesial papilla. Yes, the distal and the mesial bone. The embrasure space is going to go. The contact areas and contact points are going to be different. So once they are going to be different, all the entire process of showing the patient or making the patient aesthetically pleasing, this is going to go. Then we have, in the lateral picture, we saw that the labial convexity of the crown, you can see that there is a convexity which is seen. Now this convexity, you can see the placement. How does it matter when you are going to specifically, when we, suppose if you are looking somebody from the side, the central incision is going to be out and one of the central incisions is going to be in, or from the frontal profile, it gives a very unpleasant picture. So, if you get a patient, if there is a labial deficiency, take the implant little bit palatally, place it there. Once you place it there, automatically this discrepancy of labial convexity is going to definitely improve. So no over contouring, no under contouring, right contact areas. Okay? So these are some cardinal rules which you have to follow. So you can see here, what we can see is this is not done properly. Then after that it has to be removed, refabricated, put it back, and this is what we get when we have the final outcome as far as the aesthetics is concerned in class. Now, surface of the crown. Yes, surface of the crown is very important. Why it is important, we are going to see now. See here, what do you see here? See this and see this, the surface texture. You see here. Now this is blending in the exact anatomy where we have the grooves, we have the mamelons, we have the translucency. All these characterization, when it comes to you, you have to be properly working on it, telling the same information to your technician in the form of work authorization. Once you do a proper work authorization, you make sure the technician follows to the T what you have said, and then the final results would be really, really mesmerizing. Now, what do you see here, guys? What do you see? Okay, shade is one of the factors. What else you can see here? What happened here and what was here and what happened here? Yes. So, yeah, so what could be the problem here? So let's see. The color or shade and translucency of the tooth. Yeah, you can see. So all these factors, when you come into picture, what happens is you give everything to the technician to do it. But what happens there? The technician does not get the information what you want, and you yourself sometimes don't know what information you want to give to the technician. You are completely dependent on him or her. So here, you have to chart out all the possible outcomes what you need to, and then send the correct things to the technician. What is the problem here? Come on. Anyone? What is the problem? Here and here, what is the problem? Yes. So somebody said, if I understood it correctly, this is the incisal edge and this is the incisal edge. Again, when we are going to see the patient, it is going to look very, very odd. This is down and this is up. Yeah. So this is the position of the incisal edge. So the position also has to be bent in the same manner, and you see it now. Can you see how does it make a difference? So all these nuances specifically to white aesthetics has to be mentioned. Now, from white aesthetics, from the hard tissues, let's shift to the bone. The bone is another type of hard tissue which we need. as I told you earlier, what we have to evaluate, the quantity and the quality. So this has to be done during your screening of the patient before you put the implant into the patient. Now you see here that we have to have a labial or labial cortical bone, or let's not say cortical, but the labial buccal bone in the maxilla has to be at least how much? 1.8 to 2 mm. For the soft tissue to be healthy, no recession to be found, we need to have a buccal bone which is about 1.8 to 2 millimeters. Is that clear? Once it is there, we are going to have the right amount of bone for placing the implant into the place where we want to. If this is not followed, the implant is going to shift towards more buccal side. So as I told you earlier, many of the times over enthusiasm of this placing the implant thing leads to perforations in the bone, leads to sometimes dehiscence, sometimes perforations, and resulting in the failure of the implant, not just aesthetically, but overall failure as well. Okay? Then, of course, we have one more case. I am telling you palatal. You kept your implant palatal. Now what is going to happen? Too much of placing of implant on the palatal side also is going to affect the aesthetics, because in order to compensate that too much of palatal, you need to design your prosthesis where you are going to create a prosthesis which is basically a ridge lap. So once you make a ridge lap prosthesis, the hygiene is questionable, and maintaining that hygiene is questionable, and therefore that particular implant is going to definitely face plaque and thereby inflammation of the gingiva, followed by, not taken care, it will be followed by, periodontitis. So then you can see here in the background, what do you see? Yeah, so we spoke about the gingival biotype. Here you can see that the gingival biotype was also thin, and placement of the implant was also very much labial. So therefore, you have to have the right amount of gingiva evaluation that is done in patient selection, and then at the same time, right placement of the implant in the aesthetic zone. Now guys, coming on to the placement of the implant into the oral cavity. Now we have done the evaluation, pink aesthetics, we have done the white aesthetics. Now chances come for us to place the implant. Now placement of the implant, we have to observe in three particular starters. One is the apicocoronal placement, the other one is the mesodistal placement, and the third one is facial-lingual placement. So basically, always think implant in a 3D. Facial-lingual, then we have mesodistal, and we have the apicocoronal placement of the implant. So once we do that, what we have here is certain cases which has to be seen. Now you see, this is the zenith point. The implant is already going very much inside. So what happens there? It definitely creates very unpleasant anterior aesthetic zone in this particular case. Then, sir, good morning. We have a mesodistal dimensions of the implant, where I spoke to you earlier that we have to observe very categorically the mesodistal placement of the implant. Specifically, it comes with when we have two or sometimes more than two teeth missing. When you calculate the space, you feel okay, we can manage it, but it is going to create some space. You try to spook one more implant into it, and then you find that the third or the implant which is near to the adjacent tooth is basically encroaching the papillary space. It is going to reduce the papillary space. It is going to reduce the embrasure. Once it is going to reduce the embrasure, it is going to directly affect the hygiene of the particular which is going to be there, and at the same time, once it is sitting onto the papilla, many of the times it is going to create the crestal as well as the marginal bone loss associated with it. Then we have, of course, the diameter. Okay, this is a little bit of controversy which is here, where we have the diameter of the implant, which is they say, okay, diameter you should always, so as I told you earlier, what you have to evaluate is, evaluate the buccolingual or facial lingual width which is present already. Then you choose the diameter of the implant. But what they say is specifically in 1 in 14 with Small and Ross group of colleagues, they said if we are going to use a larger diameter where the bone sufficiency is not there, there will always be form of recession in the aesthetic zone, and that managing, you can see what happens here is the management of that aesthetic zone cannot be dealt very easily. Then coming on to the different biomaterials type, okay, I would just give you certain context of it. So we have the monolithic translucent zirconia, which basically has very good aesthetic properties as compared to YTZ. YTZ and monolithic, if we compare, we have a very high aesthetic properties between the two. But having said that, lower strength values are seen in monolithic as compared to the YTZ. Okay, so we have to choose between the better, which is going to, where it is going to be put, how it is going to be put. If it is in the aesthetic zone, you want more translucent, more aesthetic properties, definitely we are going to have the choice of monolithic zirconia. Now, coming on to the survival rate of all ceramic materials, we have here the alumina, which is 96.8%. We have the zirconia, which is 91%, close to 92%. We have monolithic lithium disilicate, which has got the 91%. And of course, we have the hybrid resin ceramics, which has got, it is a value of 67% only. Now, age-old metal ceramic restorations has 98.3% of 5-year survival rate as far as the literature is concerned. So, guys, let's see here. What do we see here? Which implant has been replaced here? Which tooth has been replaced by implant? Anyone? 1 month. Okay. Closer look. 1 month. Okay. Yeah. Now, let's see here. Come on. Okay. Okay. Now, how about here? Guys, we are almost ending. No? Okay. How many of you thought about this? Nice. Yes, guys. Thank you so much for your patient listening. And I welcome Nikhil sir here. Sir, good morning to you. So in case if you note down about the references, take down the references if you need to. Or, yes, guys. Thank you. Thank you, guys, all of you. Thank you, ma'am.
लाइट्स ऑन करवा दो. Thank you so much, sir. It was the wonderful session. Now I would like to invite Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir and Dr. Yash Sharma sir to felicitate our speakers. अफसल सर का है, अफसल सर. Now I would like to invite Dr. Afzal Ali sir on the stage to collect the memento. Many congratulations, sir. Thank you so much, sir. Now I would like to invite Dr. Preet Jain sir on the stage to collect the memento. Many congratulations, sir.
Once again, thank you for collecting.
Thank you so much, sir. Now I would like to invite Dr. Nikhil Verma, sir. He is the Dean of Gitanjali Dental College and Hospital, Udaipur. Topic for this session is failures in FPD.
पहले तो मेरे को ढूंढना पड़ेगा वो है कहाँ। हाँ हाँ है ना सब मिल गया।
ऊपर लगा के देखते सही इसमें क्या
उसमें लगेगा ये।
अच्छा इसी में लगा कंटिन्यू करना टच नहीं है ये क्या बता रहा है
क्विट कर दो।
एडजस्ट हो जाएगा लग जाएगा।
ये लगाए तो है
स्लाइड चेंज
हाँ हो रहा है, हो गया काम।
So, good morning, everyone. Good morning, everyone. I feel that I see a massive crowd here sitting to the last. You know, people really have spent a lot of time, money, and energy to make this event. And here we are with some few people sitting here, either with compassion or with a passion to learn knowledge. So, whatever it is, prosthodontics has always been bread and butter for our dentistry. And I have never realized why bread and butter. No, why not chicken butter? No. Why it is called in bread and butter? Because you earn, and the bread and butter कौन खाता है? आप खाते हो, they are good. आप अमीर हो. Bread and butter एक टाइम पे इसलिए बोला था, and when this quotation was probably 30-40 years back, the people who could eat bread and butter were Britishers. Okay, so they used to earn handsomely. To earn that, you can eat that. Okay, and prosthodontics is a science where you actually can earn easy money. Also will earn a 55,000 rupees doing a case for a year. Okay, a prosthodontist might earn a similar amount in 3 days or 15 days. Okay, probably and come out, you can earn into lakhs also with the smaller span of time. So with this mindset, every graduate who is passing out, okay, he is in the same mindset कि हाँ FPD आनी चाहिए, पर FPD आती नहीं है. The problem is we know, but we know very little, and that makes it very complicated. When the patient comes to you and you have earned a easy money of 55,000 rupees, patient comes to you after 6 months or a year, and you really don't know what to say. Starting clinical practice, you need to have one thing which is very, very good is aim, a focus. I always try and convince my students in first year and second year that if your focus is not there in first year, second year, you cannot build up your focus in third year and final year. You need to have focus what you want to do. For example, if you are into any college, I am taking some time to give a brief. Start with a failure, a meta-analysis of durability data of conventional peg bridges. This is very important. कि when you give a bridge, a patient will ask you, कि sir ये कितना last करेगा? Case history के अंदर last point क्या होता था? Treatment planning, उससे पहले और एक वर्ड होता है उसके बाद prognosis. What do you mean by prognosis? Outcome. Okay. When you say I have got a cancer, doctor says I treat you and it will survive for 5 years, 7 years, 10 years, that is the outcome. When you give a FPD to the patient, what is the prognosis? Patient is going to ask you, doctor, I am going to spend this much amount of money. Please tell me how long it will last. What do you say? First thing which flashes into you. Anybody, any answer? बताओ बेटा. ये आप सुनो सुनाए वर्ड बोल रहे हो. क्यों नहीं देनी चाहिए गारंटी? कंपनी दे रही आप ही दो.
सर एज अ प्रैक्टिशनर मैं ये जॉब होगी जब आपने रिकॉर्ड के पेशेंट को पैड नहीं निकाला तो मेरी एक्टिविटी को क्या निकालोगे तो जितना वो क्लीन रखेगा तो
ये साइंटिफिक डाटा नहीं हुआ. आप ये इंडिया में बैठ के बात कर सकते हो, यूएस में बैठ के बात नहीं कर सकते हैं. आपको साइंटिफिक बोलना है. आप पेशेंट को पटाने की बात कर रहे हो, पेशेंट को बरगाने की बातें कर रहे हो. This doesn't work in practice. Any person like me comes to your practice and say, and if you tell me this kind of thing, I'll say I'll not come to you next time. Do not tell the patient that I cannot give you prognosis. There is a prognosis for everything. You buy a slipper, you say आप चलेगी यार, 10 साल चलेगी, कितना मत करिए आप. लाइफ टाइम वारंटी उनको मांग रहा है, कब तक चलेगी? I get a feeling cases which are really good. Okay, you have to choose really cases where you actually wanted to give FPD. If the canine is missing, canine lateral sentence is missing. Okay, 1, 1, 1, 2, 1, 3 is missing. What do you do? What is your treatment plan? We even started here.
Thank you.
We are discussing on it. Anybody? Your practitioner, beta batao. Yes, yes. Great. Involving which apartment? Apartment क्या लोगे? It's not a viva. We are just discussing. Just attempt. 4. नहीं कोई नॉन करोगे. करना रहेगा. FPD देना चाह रहे हो. When you have 1, 3, 1, 2, 1 missing, what do? You involve 1, 4 and 2, 1, 2, 2. Yes or no? And it is written in your syllabus. If a canine is missing along with one more tooth is missing, FPD is contraindicated. You chose the case, you will have to do it. Because you are devoid of knowledge. So you have to have knowledge to perform a skill and then comes the experience. Normally we do it ulta. We perform the skill, then we have experience, then comes the knowledge we need another. It should be this way. Should be this way. So predicting your outcome is most important. You can predict only when you have a total control on your outcome. Total control will come only when you know what you are doing. Okay. So a meta-analysis of durability of data of conventional fixed passive bridges. Okay. There are so many data which say after observation period of at least 5 years. Now this is the article of 2004. I was trying to search many articles on failures of FPD. Okay, there are not many articles. Okay, and there were so many variables were there. You see this table, survival of conventional FPD. Total of number of FPDs by this many authors were there. Okay, mean follow time was 6 years, 15 to 18 years. Number of FPDs in situ means in the mouth. Number of failures, okay, is 35 out of 103. Okay, total FPD exposure time is 2532 months. Okay, so FPD failure rate, okay, that was 0.014%. Okay, so now what I say is, now these are different. I'll go into further decipher of these. The pooled rates, the estimated failure rate was 95. Okay, you are struggling to you gave a FPD, that's the most common thing. You gave a FPD, patient comes to you after 7-8 years saying that doctor I have a pain and that pain is due to loss of vitality. You remove your FPD. Now, what is the common practice of doing a FPD? Different schools have different thoughts. Okay, if you are doing if you are replacing a missing tooth, like if you are replacing a 6, Second, we don't give much of clearance. Okay, our technicians are not really very trained. They don't have a lot of things which are supposed to be done in FPD. Okay, they don't have good ceramic to metal bond. So then what will happen? Abutment fracture will happen and material compression will happen. So India, these two things are really very common. Loss of abutment tooth of vitality. Again, these are data. Okay. So most common fixed partial denture complications, they were caries, need of RCT, loss of radiation, aesthetic, periodontal disease, tooth fracture, process fracture, and porcelain veneer fracture. And you can see that how many indices are in there. Okay. I'll not go much detail because the अपने आप में बहुत detailed चीज है. Okay. So this is all are indications of FPD. You have fractured tooth, you have a diastema, you have adhesion, you have vascular teeth, all are indications of FPD. This is the patient. Okay. Again, these are what? Missing teeth. They are indications for what? FPD. Yes, you can give implant, no doubt in it. Okay, patient doesn't want to go for it. Okay, then you better try to do what? Now what is this? See the last one. This is a classical case which came in 2005 to me, saying that doctor, I went for orthodontic treatment, and after ortho this was like this. I'll show you the post of this. Okay, the canine lost its vitality. You can see it is easily disturbed. All teeth have really come out. Okay, they have supra erupted. Again, a missing tooth, and this is your view when patient is trying to show you. You see faces that time. This is FPD. You are happy with it? No. What is the problem with it? Pardon? Space. Okay. And Janet and I say that shade is not matching. It is monochromatic. Ginjavali, you can see that black line is there. Okay. Even if the tooth is discolored and you have to give a FPD in that, at least you can match the shade. Okay. So this gingival hemorrhage side, it's not, Janet, you have already told, because this is not a good FPD. What do you do? This fracture, this is the repair. You can do it composite also, it will not last long. You will have to see the incisal guidance there. So, how might our FPDs fail? It's a big question. They can be biological failure, they can be mechanical failure, they can be aesthetic failure. And believe me, all three failures are created by you itself. Okay? So, what are biological failure? Caries, anotic problem, periodontal problem, occlusal disharmony, and tooth perforation. Let's go by the examples. Biological failures, marginal leakage, incomplete removal of caries, and oral hygiene or caries index is too high. When the caries index is too high, don't go for FPD, try to go for an implant. Okay? And if you feel that you have to go for how many of you prefer composite over GAC? How many of you prefer composite over GAC? You love composite? Okay. Last line of treatment. Where is the indication for GAC? Pardon? Cervical abrasion. Okay. Last side cervical abrasion. And first indication, always remember is high caries index. Don't give composite there. Because you are etching enamel. You are making more prone. So when you have a high caries index, excavate the caries and try to go for what? GIC always. Okay. So incomplete removal of caries, very common theme. Very, very common theme that because your nuclei carbide burrs, which are effectively removing caries. They are not done on aerotels, they are done on micromotors. You need to find those burrs. When patient complains of pain, if the patient is saying that I am in pain, while you are removing caries with the aerotel, you have to shift to other instrument. Either it is a hand instrument, or it is your air motor or micromotor. Okay, so you need to really look for that. Now these are the caries. That is not my photograph, it's some book I have taken from. Caries under the abutment teeth. Again, a caries under the abutment teeth. And this is very common. And this is called a gingival polyp. Gingia was grown into it. Okay. This again caries under the abutment teeth. No, I just came. Yeah. This again perforations. This is what? Aesthetic failure. Again, there is a close up of that. Okay. I'll show you this case. I don't need this case. I'll show you the completion of it. Okay. It is already there. Start with this. This is the temporary which I gave. Okay. I'll show you why this case temporary I have given like this. This case came to me when I just initially started my career. Okay. And patient came to me in some private where I was called to manage this case because they had already given twice to the patient. Patient was not happy with the aesthetic, so they could charge him more. At that time, charging 1900 rupees aesthetic was a big thing. I'm talking about 2002. Okay, and they had already given 2 times the aesthetic. Now they have to pay from their own pocket. If I had third process has to be made. I went there. Patient was not allowing me to do the proper prep because patient age was 16 years that time, and the pulse was really very large. As a practitioner, I could have given an RPD, waited for another 3-4 years, okay, and then attempted it when the patient was above 20, okay, and you could easily see from the X-ray, okay. Anyway, I only gave you the FD, and I was really very happy with that. I didn't take the money from the doctor, and I said this is something which is failure I have created. Patient searched for me for almost 5-7 years, and patient came to my clinic now. In 2007 or 2008, he entered my clinic, and I took a photograph that time. And she was in pain that time. This was the picture again I had taken. I removed the FPD. First I did here, she was about to get married that time. And she was very conscious about her aesthetic. Whatever aesthetics I am having, I am happy with it. Don't play my aesthetics. Okay. Just do something. Okay. So, moment I come to you and go out to clinic, I should have my teeth. I will not be without teeth anytime. What I did was, I did RCT from the existing FPD. And that's why you could see the perforations there. Okay. Molar, they already had a perforation. So, I did all the RCT. I did the post-in core. So, you can see the post-in core. I prepped them. Then I gave that temporary. And this is the final process. Okay, now if we go back again, what was missing? Laterals was missing, bilaterally, and your premolars was missing. Okay? So what we did, you didn't have place for laterals. So when we gave a FPD previously, we gave the technician gave lateral cells in between. What in here we did was we converted those canine into laterals and we removed one premolar. So this is the central incisor. We gave a broad central incisor. This is a canine which was converted into lateral. Okay, then a canine, and then first premolar animal. So this is how we managed. So they were supposed to be how many teeth? 12. 6, 6, 12. What we gave is 10. Endodontic problem, provisional restrictions are not placed. This is very, very common. Very, very common. If you are having a non-vital tooth and if you want to give it 2 days, okay, that's okay. I still have a, I say it is okay for 2 days. If you don't want to touch a gingiva, you want gingiva to be healthy, okay, you can 2-3 days you can take to give a, final process you want to give it that you place your temporary well. I mean, you just make sure that it really plays there. Temporaries are placed. Okay. Perforation of the FPD, luting failure, galvanism, and coolant is not there in FPD or overheating. पानी देते हैं आप. So this is again a perforation. This is again a perforation. Periodontal problem. They are local factors. They are general origin, which are of systemic diseases. Local factors are over contoured respiration. All are really very, very common while you are doing a FPD in here. Okay. You have over contoured FPD. When you will have over contoured FPD, over contoured FPDs you will have when you have not prepared your tooth properly. When your margin was supposed to be 1.5 mm, you have prepared only 0.5 mm. The technician will have to go out of the tooth and prepare FPD because he needs a metal, then he needs to place ceramic. So obviously those FPDs will be bulky. Okay. So you have over contoured FPDs, poor margin of operation, interdental pressure, pontic, very poor design. Normally, all technicians are doing what? They are doing you a ridge lap pontic. Okay, or a saddle pontic rather. Okay, you should not go for a saddle shaped pontic. Then poor polishing or rough surface. This is very common on the underneath side of the FPD. Okay. Then encroachment of the biological bed. We'll discuss about biological bed. Now this is pre-splashment has done this. How is it? A RCD tooth with what is the restorative material? No, it's not a miracle. It's a miracle, right? A FPD was placed. Okay, so this looks a good FPD. Yes or no? Metal ground, eh? Patient wanted that. Is it good or bad? Seems to be good. Let's enlarge it. What's there? You have lot of marginal insufficiency. Okay? There's a lot of gap. Is it prone for caries? Okay, so marginal adaptation is not there. You really have to see. And sometimes if you are not able to see with your naked eye, you need to have a magnifying glass for that. Enlarge the thing and see what you have done. It is not, while we do a restoration, how many people are actually taking after restoration, post-operative or post-restorative x-rays? How many were taking? No. Should always take that. Should always take that. When you have done a restoration, okay, you see your x-ray, what you have done. Because that is the result you have achieved. And if you don't see it, you cannot improve it next time. Otherwise, you will be making that. That is called a systemic error. Every time you make the same error, until you take action to see what mistake you have done. And what is the common mistake in class 2 while you are making it? You are encroaching the biological bit. You will be over contouring. Your margin will not be merged properly while you are doing it. Okay. Make sure that you are using a digital dentistry or magnification there while you are doing your restoration, whether it's RCT or whatever it is. Okay. Margin integrity. So these both are. Can you tell me which is the FPD? Which is the crown in this? See the air bubble here? Okay, I purposely left that. Okay, I purposely left that before clicking that photograph. See, margins are really very good. Okay. See, these are again a faulty processes. This is encroachment of biological bit. This is encroachment of biological bit. What will happen? The gingiva will recede after some months. Okay, so never try and approach the Okay, this is gingival sulcus. Then you have a junctional epithelium. Okay, and after the junctional epithelium, you have a connective tissue. Okay, so this entire thing is 3.04, and this was first time given by Gregory in 1961. Now, once you approach the junctional epithelium of connective tissue, okay, there is a crestal bone here which is at least 1.5 mm should be left. The moment you encroach this area, the resection of the bone will occur. The crestal bone will resolve. Okay, so what you wanted to give a subgingival margin. If you want to give a subgingival margin, you cannot. You have to place your margin within the sulcus area. You cannot place it here. If you try to place here, the bone will resolve. That's what is called a biological width. It maintains its width biologically. Okay. So whenever you see X-ray, you are supposed to see the. Now you can you see it with your X-ray also in the junctional epithelium and all those things? Well, with digital dentistry, it is possible. You can really make a contrast there and you can see that. Okay. But what about the labial area? You cannot see this area. So while you are placing your margin, try to be very cautious that you place your margins in this only. Okay. You place your retraction cord. Okay. And then you place your margins. So this is again margins which are encroaching it. Okay. But this is a temporary. See, these are the rough surfaces. This again, these all are common mistakes of the PGs. Okay, while I was clicking the photograph, I was saying that it's good, I clicked the photograph. They were happy. Okay, then I should tell them this is a mistake. Okay, so this rough surfaces do what? It will accumulate plaque. Again, see the margins. These are what margins? These are all supraangular margins. I needed retention, I was not bothered about aesthetic in that market. Okay, patient hygiene is most important to me at that time. So still, this is the margin, this is the, see how it is nicely adapted over your dye. See this attitude. And then in the patient's mouth. Try and give supraangular margin as far as possible, easy to maintain. Occlusal disharmony, premature contact, TMJ, trouble will be there, palmitis will be there, occlusal scheme, canine guidance, unilateral balance, bilateral balance occlusion. I'm not covering this area right now because it's very complicated. Okay, we'll discuss FPD occlusion somewhere time. Tooth perforation, if you are left to structure like lower central incisor, too much taper to compensate for the path of insertion. Well, this commonly happens when you are doing a PAHER abutment or you are trying to replace from lateral to lateral, I'm saying, and you are trying to do from premolar to premolar. You have to involve canine and you have to involve the first premolar also. That's the point of Shinul. Okay. So, if you are doing that, what will happen? You have to maintain taper of 4 teeth. Normally, how we do it, you make a check cast, you see that as a naked eye, or if you have surveyor, it is really good. Okay. Or if you don't have surveyor, you give the temple to the patient, take the final impression, send it to your technician and a good lab, they will have a survey. Okay. Let them survey it, they will tell you where the margins are short, where the margins are problem, or where the taper is the problem. Okay. They will mark and send it to you. It will come to you the mark, you modify that, again make a final impression and send it to the lab. So this transition might take time. Don't promise the patient that I'll give you. Don't do that. Tell that we are sent to lab. Okay, when any modules are to be there, to be done, we'll do it. Okay. Take patient into confidence while we are doing this taper will be solved. Okay. The taper will be solved. Just to structure like lower central incisor or lateral incisor. Very common problem. Okay. While you are doing an FPD, if you are missing central incisor there, be very cautious. Dye preparation itself is very difficult there. And that's why they have come with epoxy resin dye. Use it here. Okay, because they break on a tooth. Okay, so epoxy resin is used, but make sure the abutment fracture is going to be there. So if you are sure about it, do a RCT, make place for the posterior core, and then do a FPD there. This is a over tapered, restoration. See the margin here. Okay, this is something which he was learning. The student was learning and he perforated. That's okay. commonly are doing what? They are doing gingivectomy. Okay, to manage that without noticing how much of attached gingiva is available. If you don't have much of attached gingiva, don't go for gingivectomy. There are ways to manage your short clinical rounds. Okay, this is the long plan measure. So once your 3 pontics are there, the force increases to the multitude of 27 times. This is short clinical rounds again. So your crown, this is arc of rotation. This is called the arc of rotation. A SPD will try and rotate when we are talking about what? Resistance form or retention form here? Resistance form. Retention means, see, retention is something which is vertical. Resistance is what? Horizontal forces. Okay? So now this, when a patient is going to chew from here, suppose this is the cusp here, patient is going to chew from here, this SPD is going to be lifted from here, but here there is a resistance because of arc of closure. So this SPD will not lift up. But in here what will happen? It will easily lift up. Why? Because of the taper. Taper was not provided, it's over tapered respiration. Now, one is taper is given too much. Secondly, the short clinical round is there. So how do you manage this? Just give one groove. Just place one deep groove here. You place a groove, your arc of rotation will be restricted to this place. And you will have beautiful rotation. So just give one groove here, one groove on the side. Okay, this I am talking about when you have done a root canal to that particular tooth. If you have not done a root canal to that tooth, it is very risky. Okay. Again, short clinical round, very fast. Okay. How? I mean, you can manage this. Yes, you can easily manage it. This is over tapered. Just finish off this taper. You will get a very good retention in this. Now, patient comes to you that I'm having these kind of problems. Cold and sweet sensitivity in a SPD. Halitosis, up and down feeling of bridge. There is bubbling up. Immediately predict that the lute has gone. It is a bridge. It is a bridge which has not come out. This is before it comes out. Before caries might happen there. Okay. These are the signs you will get. Okay. So try and press the SPD. If there is bubbling, you say that lute has blocked and you have to remove the bridge and re-cement it or redo it, whatever it is. Always try to redo it. This is how I was telling that you can predict your retention. Connective fracture, you don't use shoulder nowadays, but in the classification, shoulder joint, that is a joint porosity, wrong choice of shoulder material. Then cantilever joining, that is double abutting, deep overbite or pore planning. Okay, so if you are missing canine and you have a short clinical crown of a premolar, okay, then you can go for 2 premolars and then hang your canine around. It's better that you make a bridge only. Involve a premolar and lateral third and give a bridge. Okay, so this is a double abutting. Okay, a pontic is there. So always try and fracture. Connector failure is there. This will happen only if you don't have enough of connector width. What is the ideal connector width of PFM? What is the ideal connector width?
1/3 of the height of the crown that we do.
1/3 of the. I am talking about short clinical crowns. That's why it is always given in mm. Okay, it is given in 2.5 mm minimum. And if it is your zirconia or any kind of horse ceramic, try and give 4 mm. Okay. Anything less than 2.5 mm is prone to fracture. Okay. In a posterior toe, in an anterior 1.5 mm also good enough. Tooth fracture, inadequate tooth structure left after preparation, caries not removed completely, heavy occlusal pressure. So again tooth fracture and the caries beneath. Porcine fracture, very common and really this is the most common failure everybody fails. Okay, high points, that is the most common thing because He'll abrade the opposite tooth and give you, because he wanted to give FPD. Okay. The you who made a condition like that he should make a modification. Okay. Porcelain porosity crack. This is very, very common if you are not having good technician with you. Okay. Poor adherence of metal with the porcelain, poor designing of metal substructure. Again, these will be with the poor technician only. This will happen. Patient comes to you like this. What will do? It's a functional cusp failure, okay? It's a functional cusp failure. So you can repair it, you can, your technique to repair the porcelain also, but the aesthetic will go off. Better that you remove it. Okay? And you see the fracture has happened between ceramic and ceramo-metal joint also. Okay? So I will say this was not a fault of a oxygen only, this was fault of ceramic also. Your technician also. There was a lot of, the oxygen bond was not enough with ceramic. It was oxide layer, it was thin. It was double oxide layer. Ceramic fracture and repair, well, we do it. Okay, but they are not every time very good or every time very successful. Okay, I mean you need to have a lot of experience to do it. Cementation failure, cement fluent film thickness, biting pressure is not maintained, very common. You have given FPD to the patient, patient comes out and talks to you. You have told the patient that please bite on this for 20 minutes, don't speak anything. But patient को जैसे ही आपने bottle लगा के भेजा है, patient will come and talk to you. Doctor अब क्या खाना है, अब क्या पीना है? So you have given the instruction, but in India what happens is the patients are really very, very talkative. They want to really again confirm with you. Okay? So make sure that you instruct your patient that biting pressure will not be removed. Say them rather. Okay? Because failures are not his, failures are yours. You are failing. The bridge comes out, he said, Doctor साहब ने लगाया था, निकल के आ गया बाहर. That time you cannot tell to the patient that you didn't maintain the biting pressure. Okay? So cementation method very, very important. Thermal sensitivity. See here. This bulk of GIG is remaining there. Okay? This is my case only. I only saw it after 2 days. I did a cementation, I thought I have removed everything. I gave a carpaccio on top of it. Okay, and after while I was giving carpaccio, I noticed there was still cement there. And then I removed it. Acidic failure, shade mismatch, incorrect contour, metal color exposure and gingival recessions. Again, midline not placed properly, interdental papilla, black triangle seen, contact point not properly designed. These all are again your aesthetic failures. One of them, this interdental papilla is encroached. See here. This is interdental papilla which is encroached. What will happen here? Gingival recede. Yes. Again, black triangle. This again encroachment in gingiva. See how it has responded. Okay. It has gone ulta. It has not receded. It has gone what? It becomes inflammative. Okay. When patient will definitely complain of what? Long term it will recede. Patient will complain. Now here the inflammatory cells are there. They will cause what? They will cause the crestal bone resorption. Then gingiva will recede, and you will see the black triangle. Metal cola exposure. The problem is gingival trauma, wrong choice of metal porcelain material, solution, cordless PFM or a all ceramic restoration. Now cordless PFM, they are not much used by technicians, but they are wonderful restoration. What you do is you use the shoulder portion. If you have read the shoulder portion, what you do is you from a finish line you cut short the metal by 0.5 mm, and then you use the shoulder portion and you give it to the patient. So again, metal color will not be seen only. But what is the common combination of that? That part catches. Okay, so you need to have a good shoulder portion and a good technician to fabricate it. This is specific student only. Gingival recession, gingival trauma, gingival collar over contour, outside information, in just a minute or hour. It will take its own time, 48 hours minimum. So again, one of the postgraduates was doing a retraction and he called me, sir, retraction is over. I told patient is also over. Send the patient. You have a bleeding while doing a retraction. He cannot afford it. Okay, this is never going to receive. Remove the cord, give a temporary, send the patient, call him after 7 days. Have to prescribe some estrogen solution to them. That is stored in clumping. Retention of food due to design failure, contact point not placed properly, occlusion, margin which is not contoured. Tongue and cheek biting, very common. Sharp, rough surfaces are there, FPD not contoured properly, cusp to cusp occlusion, blunt on one side. Okay, so if you have cusp to cusp occlusion and it is blunt on one side, what will happen? The teeth can go inside. So you will have to build it up. Okay, so don't grind while you are seeing the high point, don't grind it very easily. Sweet sensitivity, there can be a cement dissolution or a loose retainer or caries. Tooth mobility, improper crown to root ratio or a failure selection of ointment, poor oral hygiene. Neuromuscular pain, that is occlusal disturbancy. Patient will say that I am having pain in my TMJ, I am having a pain in masseter muscle. Okay, but they are very later complicated. Now, I'll read all into classification. Whatever I was showing you, they were into the classification. If this is happened and this is failure, this happened and failure. Some cases I'll show you. I mean what? I'll see the occlusal pic of this. See here, a ring kind of thing was given on FPD. This is highly curious to this there down. This is the OPG of the same patient. This is how FPD was given there, using a Japanese gold. So removed by here only, some PG has removed, I think Ravi has removed. This is a beautiful case. Okay. Just see how he has designed. Please, this is worth noticing. Okay. Just see this. Alright. This is super carpaccio. This is entire metal with ceramic and this is acrylic. Okay. On 4 teeth he gave to the patient. He stuck to the patient. This is how it was made. Okay. So he could have done a overdenture, not cementing it. Okay. And given a coping there. He could have turned into a good overdenture. But this was somebody from BDS only. Okay. This is a very qualified quack rather, I should say. Okay. This is again, very commonly done here. They take some resin, they stick it in your mouth, and then they do the teeth arrangement in your mouth. Okay. Patient will be shouting, garam lag raha, koi baat nahi. Okay. So this is case 3. Case 4 is my case only, where I removed it and then I did that proper one. Case 5, again, something I don't know what he had done. He wanted to give gold to the patient and landed up where, I don't know. This is that pretty same OPG. Okay, he took support like this, subperipheral implant.
Looks like hero
So conclusion is what? Conclusion is, want to go from here to here. Life is the way we want to. But to err is human, but human is not always to err. गलतियां करो कोई बात नहीं है, पर हमेशा मत करो. Don't create your failure. Okay. So thank you. You have any questions? Are there? You don't ask questions and you do not have understood anything. You should ask questions. Apart from opening your mouth wide. That shows कि सर आपको like what to say now. Thank you.
Thank you, sir.
बहुत बोल गया नहीं मैं. Hello. से आप ले लेना हेलो हेलो हाँ
Thank you so much, sir. It was the wonderful session. Now I would like to invite Dr. Mol Bagaria ma'am, Dr. Ashish Chandra sir, and Dr. Yash Sharma sir to felicitate our speaker. I would like to invite Dr. Nikhil Verma sir on the stage to collect the memento. Many congratulations, sir. Thank you so much, sir. Now I would like to invite Dr. Harsh G. Shah sir. He is the professor and head of department in Department of Public Health Dentistry at Ahmedabad Dental College and Hospital. Topic for this session is dental aesthetic awareness among dental students. Over to you, sir.
हेलो स्लाइड चेंज है ना Yes, sir. Thank you, sir.
Thank you so much, sir.
Just, hello. Yeah. Yes, sir. What's the time? What's the time? Well, almost 12. A very good morning to all. So the last session was amazing. Sir has told us very interesting things about the prosthetics. I was the student of sir, like in this college only. So sir used to take lectures, ask questions, and अगर हम ऐसे ही बैठे रहते थे आवाज़ नहीं करते थे, जवाब भी नहीं देते थे, सर को बाहर निकाल आज अच्छा सेशन था, यहाँ से कोई बाहर नहीं निकला. Actually, I have done my masters in public health. So, last 2-3 जो भी lectures है prosthetics में आप पूरा deep चले गए हो, वहाँ पे नहीं जाऊँगा. लेकिन what actually is necessary nowadays, like आपको क्यों aesthetic पे ज़्यादा focus करना पड़ेगा, और why aesthetic is actually a need, right? और it is towards need से want तक चला गया अभी dentistry. Patient आपको पूछ रहा है, patient आपको बोल रहा है कि सर मुझे ये चाहिए. It's actually not a thing that आप patient को बोलोगे कि आपको RCT करके से tear down कराना है. Patient आपको आगे होके बोल रहा है कि सर मुझे ये ही करना है. So now the paradigm has gone or shifted to need to want in dentistry. So small survey was conducted on the students, PGs, interns and staff. Why aesthetic is important and what they feel about it. So what first thing comes to your mind when aesthetic word came? What comes to it? What is aesthetic? A good, beautiful smile. एक छोटा सा फोटो आएगा जिसमें pink lips, pink gingiva, white tooth, a line tooth, a beautiful smile. smile, a beautiful girl or a beautiful man or a handsome man. Aesthetics is like this, no? Yes or no? But that we have to create. Okay? Many of you have seen that Mahendra Singh Dhoni, अभी एक photo आया था उनका. Have you observed something?
Yes, sir.
What? Yeah, canine is missing. Right? So for that, nothing you wear is more important than your smile, because people focus on your face. So face में जब भी आप smile करते हो, you have to be perfect. Right? So aesthetic is needed. The change from need dentistry to want of dentistry. The most influential ongoing paradigm shift in dentistry began about 30 years ago with the initiation of several academies aimed at aesthetic and cosmetic dentistry. A major portion of the dental therapy is no longer oriented towards pain relief, breakage of tooth or tooth loss. Like definitely patient will come with this all complaints, but now, as sir said, bread butter to chicken mutton, you have to shift your things, right? These complaints are your bread butter, but what you find from that is your determinant, right? Is directed towards elective procedure that improves patient's appearance, thereby increasing their self-esteem, social interaction, and enjoyment of life. The ongoing change from need to dentistry to want to dentistry will continue to accelerate and increase in future times. If we see combined growth rate, it is 6.6%. Annual growth rate is 6.6% in aesthetic dentistry. In 2020, the total fund was $21.9 billion, but is projected in 2025 will be $30.1 billion. So it is a huge industry, right? So it is necessary for a dentist to explore the field in order to satisfy the existing demand of patients. The aim of the study is to access the dental aesthetics awareness among dental students. Nowadays, almost every oral surgeon or dentist is more going towards for hair transplant, Botox, right? Skin or scar removal. Right? So it is a need of time. A questionnaire survey was conducted among the dental students of Ahmedabad Dental College and Hospital about the knowledge and awareness regarding the aesthetic in dentistry. A structured questionnaire with both open and closed-ended questions was prepared and circulated to the participants through Google Form. Only completely filled online forms were included in the study. The full response was verified and the data was analyzed using SPSS software. Coming to the results, there are only 218 subjects has filled the form, as they are given short time. But out of that, 142 were UG students, which are first to final year. 24 were PG students, 19 interns to 30 staff. When they were asked which is the thing which most affect your smile, which is confidence, social interaction, psychological well-being, or all of the above, all the candidates like UG, PG, intern and staff, the major answer with more than 60-70% were all of above. So they are conscious about their confidence, social interaction and psychological well-being. And they know that smile will affect these all factors. When the second question comes, that does the color of the teeth affect the aesthetics? Yes, almost all the 70-80% students, PGs, intern and staff were positive about it. When they were asked, does the gum display while smiling affect the aesthetics? The answer was yes. Does the size and shape of the teeth affects the aesthetic? Definitely. Once again, the answer was yes. So, in this outcome, we can realize that the people or the student, even the first year students, are also also aware of tooth color, gum display, and size and shape of the tooth. When they were asked about the alignment of the teeth affects the smile, then also all the PGs and majority of the other candidates has a positive answer for that. When they were asked, are you satisfied with your smile? Here, some of the students were not satisfied with their smile. So it is again a good answer that they are actually knowing that, or they are actually aware or concerned for that smile. When they were asked, would you like to go for any smile enhancing treatment? Once again, 30% of the students or 30% of the candidates were willing to go for the smile enhancing treatment. So even in dentistry or even in a young crowd, also we find that 30% of the students or the candidates are willing for enhancing treatment. When they were asked about the knowledge that if they are knowing about what is DSD, digital smile design, do you know what is DSD? Right? It is a mandatory course or upliftment of the dentistry, which is DSD, digital smile designing. So majority of the UG students, because they have just entered, they were not aware of. So PG followed by interns, PGs and staff. So it is a normal outcome. When they were asked about, do you know the golden proportion? Do you know about the golden proportion in dentistry? What is that? Anybody? Yes. Yes, exactly. So, but majority of the GG students were not aware of that, and almost less than 50% PGs, interns also were not aware of that. So, it is necessary to aware them about this. When they were asked which is the most frequently preferred cosmetic treatment, the options were tooth whitening, veneers, Invisaligns, implants, or cosmetic build-up. The major answer was tooth whitening, which is bleaching or scaling, right? But there are other ways like veneers, Invisaligners, and composite build-up, but they were not exposed to that. That's why the answer is very common, which is tooth whitening. When they were asked, have you attended any conference for aesthetics? Only 61, like 30% of the people have attended. But when this is the practice, but when they were asked about the attitude, that what would you like to attend any workshop, they have find a good results that almost 70% people were happy to attend or want to attend a workshop on aesthetics. When they were asked, do you think aesthetic or cosmetic dentistry is the future of dentistry? Yes, almost 90 or 95% were positive about it, that it is the future of dentistry, or we can find good things from that. So what do you think? It is the future of dentistry? So aesthetic dentistry is currently basically growing a rapid pace, like implants, Botox, hair transplant, aesthetic dentistry, composite restorations, veneers. So we have to find the patients, or we have to find the treatment in the patients, right? So we can earn good things from dentistry. Hence the dental students must have the knowledge and awareness about the aesthetic dentistry. So it's my recommendation to, like yesterday I told that there was a meeting. It is also on the digital dentistry. In that also we have recommended them to add a course of aesthetic dentistry in that. short time, we came to conclusion of this study that it is a time of a revolution and innovation in dentistry. The students and the staff had fair awareness towards the aesthetic dentistry, and aesthetic or cosmetic dentistry should be included in the curriculum, and the emphasis should be laid on the enhancement of the clinical skills and the dental students to meet the demands of their future practices. Thank you. That was short, but must. Do you have any questions? I think you must be happy it's over in short time. Thank you. Can I take my pen drive? Yeah. Thank you.
Thank you so much, sir. Next up, I would like to call upon Dr. Vasudha Sodhani. Press it down and do it. एक सेकंड में हम बुलाते हैं. We'll call them, ma'am.
उधर ही क्या
एक बार चेक कर लो उस साइड पे नहीं ऐसे करके
देखो ओपन हो रहा है
zirconia this one.
Dear delegates, we have with us Dr. Vasudha Sodhani, ma'am. Her topic for today is zirconia crowns. Please, ma'am. Yes, ma'am. Pointer ke liye, ma'am. Just check if it's working, ma'am. F5.
This is right.
Yes, ma'am.
Next step, please. Pointers. Mic लगाना पड़ेगा.
Mic, ma'am. Start. It is on. इस पे लगा.
So a very good morning to all of you. I know it's time for good afternoon. Hope you all are not tired of listening to all the lectures here. So it's a small topic which we'll be covering this time, and it is zirconia crowns in pediatric dentistry, right? You all are using crowns in, for pedo patients. Have you used? nowadays been updated. Now, aesthetics is going day by day in each and every field. Same way in the pediatric dentistry also, the patient is coming to you not just for the filling of the tooth कि हाँ दांत खराब हो गया है, cavity हो गई है, आप filling कर दो बस. यहाँ पे patient को pain है, बच्चा रो रहा है, you just give the syrup and the patient will go happily that हाँ pain चला गया है. Right? That is not the thing today. The patient will say, thoda teeth black hai, we want aesthetic smile. Even they are concerned about the deciduous teeth also. It's not that it is a milk teeth and it is going to fall off eventually. That was the thing maybe 20 years back or 10 years back also. But nowadays, parents come to you, even the child decides that I want to go for this tooth. Right? They ask the child, तुम्हें कौन सा tooth कौन से कलर का tooth करवाना है, right? So you should be updated about it. So the pediatric dentistry has two. Earlier it was only conservative dentistry, which was the part of the cosmetic dentistry. But now each and every branch of dentistry has come up to the aesthetic dentistry. All the things which we discussed earlier were related to prostho, right? But you can see that in prostho also aesthetics is important. In conservative, if you are doing a composite build-up, or if you are doing a RCT followed by crown, then also aesthetics is important. Same way, in pediatric dentistry also aesthetics is important, right? So there are many treatments in many branches which have come up together and they all have jumped into this shift that is taking towards the aesthetic dentistry. Now the most common problem in children is caries, right? Most of the parents come to you in the clinic saying that the cavity is there in the tooth and they want to get it filled or RC treated or pulp therapy or whatever the treatment is. But the chief complaint is dental caries. And it has been acknowledged by WHO also that more than 50% of the children are suffering from dental caries in once in their lifetime. It can be pit caries, it can be caries extending to the pulp, it can be dentinal caries or whatever, but caries is there and we need a solution for it, right? You are going to practice in your clinical setup, every day you are going to acknowledge some or the other patient coming to you with a cavitated tooth. Yes, everyone knows that adult, okay, we are going to do composite build-up, we are going to do RCT or then we are going to place the crown. But when it comes to pediatric patients, the knowledge is very shallow, right? Because you don't get to see many patients in the college, right? So, the prevalence is increasing and it is involving at least half of the Indian population also. Now coming to the crowns in pediatric dentistry. As I told you that when are you going to do the pulp therapy procedure, you need to give the crown. हम RCT के बाद crown करते हैं, right? Same way if in a pediatric patient we are doing any kind of pulp therapy, right? Pulpectomy, pulpotomy, ये तो आता है ना सबको, हाँ. तो ऐसा कुछ भी करेंगे, then we need to give crown, right? Because why we need to give crown? Tooth becomes weak after doing pulp therapy treatment, so ideally we should give the crown, right? So crown के options, what were the previous options? That is stainless steel crown. This was the crown which was designed in 1950. See, 70 years back, right? And still we are using stainless steel crown, right? So this was the crown which required minimal tooth reduction and it has high strength and good flexibility. But the aesthetics was not good. ठीक है? किसी भी बच्चे को हम स्टील के कलर का कैप देंगे, पेरेंट्स विल आस्क कि आपके पास कोई और ऑप्शन है, right? So we need to give them options. We need to have options. So then after that the stainless steel crowns were modified. What the modification was done, that they were pre-veneered, right? So pre-veneered stainless steel crowns were available in the market in form of different market names. Then pre-veneered aluminium crowns were available. They all have high aesthetics, but in pre-veneered stainless steel crown, the disadvantage was that there was wearing off at the edges and it requires deeper penetration, and obviously nickel allergy could take place. Same way the other crowns were of the lower strength. Then coming to the acrylic crowns and strip crowns. Have you seen strip crowns? Right? It is a common procedure which is done in pedo patients. But the strength of the strip crowns is very less. Now, if the patient has come to you and there is pulp therapy needed in anterior teeth, right? Deciduous anterior teeth, 5161, 5262, whatever. So you are going to give strip crown. Then the patient will ask that what is the durability of this, because the patient is going to pay you, right? And if you are saying that the durability is not good, then how can you charge so much, right? So if you are charging the amount in your private practice, then you need to give that kind of service to the patient, that, or you need to give that kind of guarantee to the patient that no, it has good strength and it is going to survive for a longer period of time, right? Yes or no? If we are buying something, then obviously we need guarantee for that. If we are paying a huge price, strip crowns is also aesthetic. So you are going to cost, it is going to cost a fortune for the patient. Yes. So better give a crown which has better durability, better strength and better aesthetics. So the latest are the zirconia crowns. How many of you have seen zirconia crowns in pediatric patients? So there are kits available. You can get it lab made also, like the adult crowns, and there are various kits from various companies which are available in the market, right? And from there you can select the crown of the particular size and you can place that crown after doing the pulp therapy procedure. Now the history of zirconia crowns. It started from 2006. It was developed by Dr. John Henson and Jeffrey Fisher. Then in 2007, the first prototype was created. In 2008, the first crown was fitted in patient's mouth. In 2000, the sale of zirconia crowns started. So it's just been 12 years, right? And various new companies are coming in the market. Like in 2012, New Smile and Kinder crowns are available. In 2017, Kidsy crown came into the market. The properties are that it is made up of yttrium stabilized zirconia and it is either milled or injected. Then it has superior toughness. It is also called as ceramic steel and it is resistant to chemicals and corrosions. Basic properties, whatever are there of zirconia crowns in adult patients, the same properties are there in pediatric patients. Now the advantages, we all know that the advantage of zirconia crown is high strength, high aesthetics, it is very translucent, there is less tooth removable, the modifiable sizes are available, biocompatible and good patient acceptance. Just a second. The disadvantages are that in stainless steel crown you must have seen there is a set of pliers which come, right? So you can adapt it according to the tooth you have prepared. It is slightly modifiable, it is flexible. So the adaptability is more in stainless steel crown. Whereas in zirconia crowns you cannot bend it, it is not flexible, right? Then due to inflammation, gingival bleeding may hinder the bonding. The next disadvantage is that it is expensive. So some patients may not go for the expensive treatment. So you need to know about both stainless steel crowns also and zirconia crowns also. Indications are same as stainless steel crowns. That is the defect affecting 2 or more tooth surfaces, any after pulp therapy procedures, after any developmental defects, or if you are doing a treatment under general anesthesia with high risk caries, in patients with high risk caries, and as an abutment for the space maintainer. Now coming to the technique. the mesiodistal width and the most, the crown which matches the most, the mesiodistal width of the crown which matches the most, you select that crown. Now after selecting the crown, you need to prepare the tooth, right? There are two parts in crown placement. One is the crown and the other one is the tooth. So for tooth preparation, first if we consider the posterior teeth, right? We need to do occlusal preparation. Stainless steel crown also you do occlusal preparation. Same way in zirconia also you need to do occlusal preparation. How much amount of occlusal preparation? At least 1.5 mm of occlusal reduction is required. Now how do you do 1.5 mm is that you need to be exact. So a burr comes which is a donut shaped burr. You can use that burr and the width of that burr is 1.5 mm. So you prepare the tooth from the mesial marginal ridge and then from the distal marginal ridge, and then you join both the parts, right? So the equal reduction is done on the entire tooth, right? First preparing the mesial side and then preparing the distal side and then including the entire occlusal table. So in this way occlusal reduction is done. Now coming to the reduction on the buccal, lingual and proximal sides. In stainless steel crown, we don't do buccal and lingual reduction, right? Buccal and lingual reduction is not required. But in zirconia crown, buccal and lingual reduction and proximal reduction is required. Now how do you do it? You use this burr and place it perpendicular to the occlusal table and prepare. The depth of this burr is 0.85 mm, right? So you place it perpendicular and then you prepare the chamfer margin, and then you move this burr around the tooth so that the chamfer margin is created all around the tooth and the tooth cutting is done properly on all the surfaces of the tooth, right? The uniform cutting is done on all the surfaces of the tooth, creating a chamfer margin, right? After this, you go for subgingival reduction. Now, here you have prepared the chamfer margin, right? In previous slide, I have shown you the chamfer margin, supragingival chamfer margin. Now, in next, if you are going subgingivally, don't go to the entire 2 mm depth, just go 0.5 mm depth with the help of the flame shaped burr, right? So you remove the chamfer margin from here and then you move the burr again to the entire tooth surface and then remove the chamfer margin and create the uniform reduction, right? Then you can extend the, your burr supragingivally, subgingivally stepwise. You need to go deeper stepwise. That with each pass you are going deeper and deeper and deeper till 2 mm subgingival. So the uniform reduction of the tooth is done, right? The chamfer margin is gone, right? So after doing the uniform tooth reduction, in this manner if you go slightly deeper, then you are minimizing the trauma, and because you are minimizing the trauma, the gingival bleeding is minimized. If the gingival bleeding is minimized, then obviously when you are going to bond the tooth to the prepared tooth, the crown to the prepared tooth, the adhesion will be better, bonding will be better. So this is what I explained it to you. Now the things which you need to take care of is that these areas. If your burr is not going properly perpendicular, then you are going to prepare a ledge here. The cutting will not be proper in this area. Same way, if you are not going subgingivally, then the cutting will not be proper in this area. So you have to take care of these two areas. Same way for the anterior teeth. You start mesially. 1.5 mm of reduction needs to be done, the way which we did in posterior teeth. Same way for the anterior teeth. We start way the burr is placed perpendicular and the circumferential reduction is done uniformly, creating a chamfer margin. Then after that you go subgingivally and then remove the chamfer margin and the reduction is done. The same way for anterior teeth, the way which we discussed in the posterior teeth, the same way the reduction is done. Only the thing is that the incisor edge should be thin, but you don't cut the tooth, you don't prepare the tooth overly on the proximal areas. Otherwise the pulp horns are there and there are chances that you might expose the pulp horn if you are doing it on the vital teeth. Right? So after the lingual reduction is finished, it will be concave in shape, this lingual reduction. And the thin incisal arc, creating a thin incisal edge. As I showed that 2 mm of subgingival preparation is done and the margin is removed. Now, you have a prepared tooth and you have your crown, the pre-selected crown. जो हमने पहले mediodistal bit measure करके select किया था, right? So we have the crown, we have the tooth. Now what we need to do is cementation. Now the cementation part is important because even after giving an n number of instructions that don't eat chocolates, don't eat sticky food, the child is not going to listen to you, right? They get tempted. So the bonding should be very much perfect. Right? For the bonding to be perfect, we need to follow the steps very particularly. Especially the isolation should be maintained. Now the prepared tooth is clean, and the prepared crown, the crown which you have selected should be clean. It is filled with the cement, and you place the crown onto the your prepared tooth. After placing the crown, the excess cement will flow. Right? So you need to light cure the tooth. Okay, which cement we use for zirconias? Usually, which cement you use for your ceramic crowns? GIC luting, right? And for zirconia crowns in permanent teeth, RNGIC, resin modified GIC. जैसा सिरिंज देखा होगा दोनों में से एक साथ मटेरियल डिस्पेंस होता है, राइट? So that is the better cement to cement the zirconia crowns, right? So for zirconia crowns, you will fill the crown with the cement, then you will place the crown, light cure it, you remove the excess cement, check for the high point, and your crown is done, right? So the method is quite similar to the stainless steel crown method, which we are doing since ages. The only thing is that the aesthetic part, right, and the demand which is coming these days, that everyone wants white teeth. Nobody wants to go for stainless steel crown, right? So you need to be updated. You need to keep yourself updated, and you need to know that this is the thing which is available in the market. So when the patient comes to you, you are not clueless that नहीं बच्चों में तो और कोई crowns आते ही नहीं. The zirconia crowns are available in the market in various kits, in various market names they are available. So you need to have an option for the patient coming to your clinic that yes, we have the aesthetic option instead of the conventional stainless steel crowns, right? So concluding the seminar, and as per the many studies, that zirconia crowns are the promising alternatives to the other restorative materials and crowns in the field of pediatric dentistry. So you all agree, yes or no? If you get a better aesthetic option, you want to go for that option or no? And as that is the part of the patient, right? Now as a part of a dentist, on behalf of a dentist also, it is good for you. You are going to earn more if you are going to give more aesthetic option, right? You can charge more and you can earn more and you can flourish more, right? So as a practice point of view also, we need to keep ourselves updated. And they have shown greater properties and performance in terms of different clinical aspects and great
Thank you so much, ma'am. It was the wonderful session. Now I would like to invite Dr. Anmol Bagaria, ma'am, Dr. Ashish Chandra, sir, and Dr. Yash Sharma, sir, to felicitate our speakers. I would like to invite Dr. Harshji Shah, sir, and Dr. Vasudha Sodani, ma'am, on the stage to collect the memento. Many congratulations, sir and ma'am. So as we all know, yesterday we had award function. Ma'am and sir was not able to come yesterday, so we are announcing again. The award for the public health dentist of the year goes to the Dr. Harsh Shah, sir. And the award for the pedodontist of the year goes to Dr. Vasudha Sodani, ma'am. Many congratulations, both of you. Many congratulations, sir and ma'am.
Now moving forward, I would like to call upon Dr. Manish Chadda sir to address the gathering on his topic basic implantology. I request you, sir.
Laptop, this will connect. Shall I share with pen drive? इसमें कौन सा वाला पोर्ट है भाई? HDMI नहीं है इसमें, वो है। I don't have the real file. Oh, I got pen drive. अपना लैपटॉप दे दीजिए।
डायरेक्ट कनेक्ट नहीं हो सकता क्या ये वाला? एक बार वो देख लो सर।
कोई बात है, तो ट्रांसफर कर लिया, आपको लगा दो जो मेरे इसमें वो नहीं था ना, HDMI नहीं है ना।
अच्छा ये नॉर्मल वाला है
हाँ ये वाला है।
आपके
हाँ हाँ हाँ, कोई बात है, प्रिंटर में ट्रांसफर कर लिया इसलिए मैं क्या मालूम है यूज़ कहाँ
हाँ ये लग जाते हैं डायरेक्ट
कर दिया भाई, ओ प्लस कर दिया भाई। आप ही कनेक्ट कर दो इधर जैसे कनेक्ट करते हैं, मैं पेन ड्राइव में अब ये
तो ये नीचे होगा, ये ऐसे नीचे शिफ्ट होगा और इसमें पेन ड्राइव जाएगी।
अच्छा स्टाइलिश स्टाइलिश चीज़ें रखता हूँ मेरा पुराना जनरेशन कैसे करो।
हेलो
I need a pointer, huh?
हेलो
स्टार्ट करो।
This PC and pen drive कहाँ गई?
पेन ड्राइव का कनेक्ट हो गया।
Not showing? एक ही पोर्ट है USB का? उस साइड भी है?
उधर भी वो पॉइंटर लगा रखा है उस पर, ये वाला।
नहीं पॉइंटर स्पेशल कर लेते हैं, पॉइंटर तो प्लग एंड प्ले होता है ना।
हाँ।
देखते हैं अगर ये चीज़
ऑन कर लेना सर।
Okay. Good morning. Why are some people hiding in the last? Already so few people are there. Why are you hiding in the last? Kindly come forward. Last. Kindly come forward. Don't hide. These front rows are empty. I must be there. Rest are not interested. Okay, your call. Okay. May I know how many BDA students are there? Okay, so majority of you asked 10%. Okay, then I'll go accordingly. Yeah. Chalo. You people are aware about dental implants? Yes, sir. That's good. Half work done. Right change नहीं हो रही. Get out it. Slide change not perfect ना?
सर इसी में नेक्स्ट करके देख,
इसमें हो जाएगा next.
इससे नहीं हो रहा।
इससे नहीं होगा. चलो okay, it's okay. So, what is the purpose of implant? अपने आप में इम्प्लांट डजंट सर्व एनी पर्पस, कुछ नहीं. इम्प्लांट क्या करना है? पेशेंट डजंट कम फॉर यू फॉर इम्प्लांट, राइट? नो पेशेंट कम्स टू क्लिनिक एंड से मुझे तो इम्प्लांट लगवाना है. ठीक है? व्हाई डज पेशेंट कम टू क्लिनिक? Patient come to clinic because they are concerned about their teeth, that they are missing one, few or all of their teeth, right? So first thing to look into is edentulosum, condition of having missing teeth, edentulosum. So when patient comes to you, normally in a clinic, in setup, whenever patient is coming to you for missing teeth, what options we used to give? We used to give either of these earlier, before implants, right? Either if one or two teeth missing, okay, you can get FPD. Otherwise, more you might need to go for RPD. That might be flexible, that might be casted, whatever way it is, right? And the last, if all of the teeth are missing, then completed. But if you see here, only one of these option is fixed. Only FPD is fixed. Rest to आपका removal option. So natural lower teeth is fixed. So no one wants a other kind of substitute, except there is a monetary consideration. That's a separate thing. The implants are costly. That's a different talk. But implant is the best suitable substitute for a missing teeth, especially in scenarios where more than one teeth is missing, because their FPD is out of question normally, or people give faulty bridges. That is again different. So what is the implant? Endosteal, biologically compatible material, surgically inserted into the edentulous bony ridge. So the thing is, now you are missing the teeth. You are creating first a substitute for the root. You are creating a root substitute over which you will be building your prosthesis. This much is clear. Then most common material used for implant. आपका अभी हम informed के पहले भी आपका yesterday also Dr. Sahab has taken lecture on implant, so you all must be aware. आपके curriculum, ठीक है? Titanium is the most suitable material because it is biocompatible. It forms a union with the bone, and that process that it forms a union is called osseointegration. This is the basic, right? तो अपना missing teeth को replace करना है, इसलिए implant का use है. Implant को आप bone में insert कर रहे हैं, waiting for some amount of time, it will osseointegrate. Then you will be planning your prosthesis over it. इतना ही है, right? Then implant has different parts, components. So if you see a part, main fixture goes inside the bone. Then other components, screw, abutment, crown, they are the one which will be utilized intraorally for replacement of teeth, whichever way you deem necessary for that patient. ठीक है? So अभी विदाउट इम्प्लांट आपके ऑप्शंस कैसे थे? सिर्फ एक फिक्स था, बाकी दोनों ऑप्शन आपके रिमूवल थे. इम्प्लांट के बाद क्या हुआ? नाउ सीन इज चेंज. Even if single teeth is missing, no need to harm the adjacent teeth. Some people are having this perception that implant, they are invasive. That's an invasive treatment because surgery is involved. But if you see the broader picture, they are actually conservative because they are not permanently damaging any of the other tooth structure, any other structure, right? आपने जो भी flap open किया, जैसा भी किया, that will heal. A period of discomfort might be there, but apart from it, no worries. But FPD on the other hand, it is permanently destroying your adjacent teeth, right? Now, same when long span bridges were there, that time long edentulous span is there, bridges were not possible with natural teeth. अगर आपका एक lateral है, दूसरा आपके पास सीधा molar है, you cannot give a bridge. But with implants you can do that. वो भी fix हो गया. Third आपका option dentures, completely dentures है. उसमें भी आपके पास simplest, you start with overdenture, just place two in the mandible. You will have a fixture, a semi-fixed kind of attachment will be there, but it will stay very well. One, if not, you can go for all on 4, all on 6, any kind of processes. ठीक है? ये वाली बात तो clear है? तो यानी कि you all now know basically what is implant, right? चलो. Now फिर ये भी पता है कि how to place implant? Done and dusted? अच्छा, मेरे को नहीं पता था actually ना. So I thought सबसे पहले आप लोग क्या करते हो? How to place implant? सबसे पहले सर्च ऑनलाइन, फटाफट से कट 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 क्या करना है. उसके बाद में find patient with a missing teeth, Slideshow is running faster than me. Okay. So basically, whenever a patient is coming to you and क्या patient आ रहा है for identity, first you have to diagnose क्या requirement है, which type of process will suit him best, then what is his medical situation, है ना, और उसका bone situation कैसा है. अगर implant में भी आते हैं तो भी which type of process need to be planned, bone quality, number of implant, length, diameter, so lot of planning goes into it. Okay, so implant treatment is not like a ABC सीधा डाल दिया, it is more of a planning. Execution part एक है. आप लोगों ने कल कितने लोगों ने वो किया, हैंड्स ऑन किया? 3 4 5 आप लोगों ने हैंड्स ऑन किया. जिसने हैंड्स ऑन किया तो you must have felt कि ठीक है ड्रिल तो करना है सिंपल, but it is same, it's a dummy, it is not, there is कोई nerve structure is not passing through where you were drilling. Why? That is not the scenario in real patient. So that is why a meticulous planning is needed. Implant, I'll say 50% planning, 50% rest of all execution, including surgery process. First 50% you will succeed if you plan them. Okay. Just showing you some steps. Okay, what all is conventional. The first thing आपके पास आया, you have to evaluate radiographically. You have to start with say IOPA. You can palpate how much of bone is there, but then the basic tool which you have in your hand is your CBCT. A CBCT will give you exactly how much of bone is present in the area where you desire to place a root analog, right? So first thing is CBCT. अभी with the advent of CBCT, another advantage you are having is कि CBCT के साथ में आपका planning भी वही करके देते हैं आपको, है ना? So your work is even easier. So virtually on the computer only you can place implant. Virtually implant placement can be done. Virtually only say अभी जैसा है, here you can see both sides good bone is there, है ना? Situation नहीं है, you can do everything in the computer itself. So you will have a fixed determined path कि मेरे को तो यहाँ पे जाना है. So you will, the chances of going wrong will be decreased substantially, right? So planning के बाद में single implant. Are you aware ये क्या चीज़ है ये? What is this? This is a guide. Okay. When I'm planning, say I'm planning on a computer. Now this gives me a printable file. ये आपका edentulous site था, ये आपका natural teeth present है, यहाँ पे. उसके साथ support लेके. Now this is a guide. I need not cut open the gingiva. मुझे कुछ नहीं करना. Directly through this I have to go. This will take me to the predetermined path which we have adjusted while planning on the computer, right? ये बात clear है सबको? So this is for direct place, and through this only you will place your implant into the bone. Later on, restoration. Okay? ये कैसा हो गया? ये अपना most advanced जो आजकल है, but again it has a limitation. Limitation, you cannot use it blindly everywhere because software theoretically it is 100% foolproof. Because you are having a CBCT, you are having a cast, you are superimposing the images and you are placing the implant. But in reality, that is not so. Reason being, software, multiple softwares are used, so everywhere data loss is there. So you cannot utilize them in a situation जहाँ पर you are edge to edge, means you don't have margin of play. If abundant bone is there, definitely this is the best because you need not open the gingiva, it's quite comfortable, the procedure gets over within 15 minutes. है ना? क्योंकि flap opening, suturing back, everything is safe, but you have to use this wisely. Now just showing some example. Conventionally, what need to be done? Conventionally, we say patient is there with missing teeth. Okay, patient has come with a missing teeth. So first was, or again CBCT was done. We have evaluated whether some bone is there or not. In this situation, it was a little tricky because if you see here the bone was thin. This area bone was thin. Center there is a nasopalatine canal, okay, which takes up space. You cannot encroach that area. And here is a lateral incisor. So, okay. The CBCT gave us a fair idea. We could use only a narrow body implant. So that was the diagnostic step. So So the step goes like, break the patient, infiltrate. You have to open the gingiva. Conventional technique I am telling, right? So you are opening up the gingiva. Implant is placed here. Closed. Sutures remove after 14 days. Done. Primary healing done. Then comes the stage 2. We waited for approximately 4 months in this case. Opened the gingiva, made the attachments, abutment, and then process is placed. Right? So simplest case जो आप लोग अभी करोगे सबसे पहले start. But as I telling कि इस case में it looks a simple case, but the challenge was very less availability of bone. Okay. The implant diameter we placed was 3. The bone might be 4 point something. We have to use to bone expansion. Okay. Now another case. Similarly, you see edentulous side. Tissue is reflected. Drilling is done in sequence. First you reach the desired depth, then you keep on expanding till the time which is you can reach the desired diameter of the implant. सबसे पहला length, pilot drill, फिर उसके बाद में sequential expansions, then you will place your implant. So, implant is placed. Some graft was placed here, secured. Now, this is after it healed. Now this is the first is gingival former. पता है सबको जिसने कल कोर्स किया है, ठीक है? 3 महीने बाद जब किया सबसे पहले क्या डाला? Gingival form. Gingival formed around it. Then abutment was placed, and finally a crown was seated over it. ठीक है? Again same thing, but multiple missing. इस वाले पेशेंट में सेम चीज है बट immediately extractions भी करें, साथ के साथ में you have placed implants. Okay. Now this is more of prosthetic case if you are interested. See, first step was this gingiva formus. This you are aware. ये सबको पता है ना gingival formus. Gingival formus once they heal, what are these? ये क्या है? कल कोर्स किया है impression posts. Okay. अभी ये तो हो गया, हील हो गया. अब इसके बाद भी तो उसका impression लेना है ना, कास्ट बनानी है. कैसे बनाओगे? तो impression post अटैच करते हैं. Impression post के साथ में impression post को साथ में splint किया है. They are splinted so they do not shift from their position. Final impressions are made and then you receive a cast. So now this cast carries implant in the very same position जिसमें आपके originally माउथ के अंदर है. फिर उसके हिसाब से इसमें you fabricate a joint prosthesis. क्योंकि अब क्या कन्वीनियंस मिलती है कास्ट बनाने से कि these abutment comes in various angulations, but it's very tough to trim them intraorally and adjust them. When you make a good cast with a splinted cast, then you have the exact position on with you in lab. You can redesign the abutments according to your own convenience and then place. ये तो हो गया तो सिंगल मिसिंग हो गया. अभी बात करते हैं कि सीडी की केस edentulous patient, completely edentulous, right? Completely edentulous patient आए, you have सबसे पहला बेसिक ऑप्शन देखो, इसमें भी देखो कि क्या रहता है. कंप्लीट edentulous सबने बनाया ना? किसमें दिक्कत है? कभी दिक्कत नहीं, कोई दिक्कत नहीं, बहुत बढ़िया बनाते हो. जीआर में फाइनल edentulous में किसी चीज में दिक्कत आई? रिटेंशन में कोई दिक्कत आई? कभी नहीं आई. आई मैक्सिलर नहीं, मैंडिबल में मैक्सिलर में आई. किसके से मैक्सिलर में आई? अच्छा मैंडिबल में आई, किसी को नहीं आई. I just want to know. मैंडिबल में आई. देखो डॉक्टर साहब मैंडिबल में आ गई, आपको मैक्सिलर में आई. If you see ना, see mostly you will, अगर आपको देखो compared to your maxilla. Okay, आपका complete denture का retention का क्या है? कैसे retain करता है complete denture? हाँ जी? फैक्टर्स कौन से इफेक्ट करते हैं कंप्लीट डेंचर में? सुना पेरिफेरल सील सुना? नेगेटिव एटमॉस्फेरिक प्रेशर होता है उसकी वजह से पेरिफेरल सील बनाते हो, बॉटम होल्डिंग करते हो, ठीक है? फिर उसके अलावा पहले ही अभी वेरियस सेकंड ईयर में शायद पढ़ लिया होगा, अडहेशन, कोहेजन, कैपिलैरिटी, सरफेस टेंशन पढ़ा था ना? तो एक आपका जो पेरिफेरल सील बनाना है वो आपका जो एटमॉस्फेरिक प्रेशर है वो कब वर्क करेगा जब अच्छी सील बनेगी। अब मैक्सिला को एक और एडवांटेज है, वहां पे टंग कोई मूव कर कोई मूवेबल स्ट्रक्चर नहीं, आपने पेरिफेरी को अच्छे से मोल्ड कर दिया, अब आपके पास कोई मूवेबल स्ट्रक्चर नहीं, सो यू कैन गेट अ वेरी गुड पेरिफेरल सील एक्चुअली। थोड़ी सी मेहनत करो। मैंडिबल स्टोरी माइट बी डिफरेंट, माइट बी, बिकॉज टंग इज hypermobile organ, or someone comes to you with a long span of edentulous, they have enlarged tongues, okay, then it becomes even more challenging. Of course, there are techniques. There also we have neutral zone. We have so many ways to rectify complete denture itself. It's not that nothing is there, but comparatively हम करें कि अगर patient का बहुत ज़्यादा portability नहीं है, तो भी बहुत satisfactory process बन जाता है अगर आप mandible में सिर्फ 2 implant डालते हैं. Maxilla, give us denture, mandible में put 2 implants. Those 2 implants will act as over denture. They will provide them retention points, and patient will be able to chew very well. Okay, this case is not of that. This is basically patient wanted fix, but going segmentally. So CBCT was conducted. What are these? क्या लग रही है? हाँ जी? Any guess? Radiographically, you can make out these are some radiopaque structure. This you can see here, na? Tell me that these are some radiopaque structures. So what are these? Are basically, see, अभी starting का case दिखाया, first case, उसमें कौन सा missing था? Central incisor. मैंने flap open किया, कोई confusion नहीं है, इधर भी दांत है, इधर भी दांत है, मेरे को बीच में ही जाना है, और तो मैं नहीं जा सकता, ठीक है? But edentulous में क्या होता है? When you completely open a flap, उसके बाद you are not able to make out midpoint कौन सा है, lateral कौन सी position पे, canine exactly कौन सी position पे. There is no reference point. So before going in for CBCT, you use some radiographic markers. Okay, आप एक template बना के उस पे radiographic marker लगा के करते हैं. So now this will help me in planning. देखो ये midline है मेरा, ठीक है? अब मेरे को ये पता है कि मुझे midline से कितने मिलीमीटर पे डालना है. Next फिर कौन से पॉइंट पे है, क्योंकि ये मैंने पेशेंट की कास्ट पे बनाया. दैट टाइम आई हैविंग अ रेफरेंस. गेटिंग दिस पॉइंट? Radiographic marker. Just remember, these are radiographic markers. They are very helpful. So when you're sending for each edentulous patient, if you are going for CBCT, any scans, and you wish to place free hand implants, then definitely have these markers beforehand. So you are having some mental orientation exactly कहाँ जाने वाले हैं. ठीक है? क्योंकि अभी क्या किया, ये फ्लैप खोला, फ्लैप खोलने के बाद में फ्लैप ओपन, गेटिंग नहीं? अभी देखो खोलने के बाद ऐसी पिक्चर दिखती है, तो एग्जैक्टली कौन सा कैनाइन है, कौन सा प्रीमोलर है, टेंटेटिव you know, but it becomes little tough to get your hand around it. So it's better to have some markers with you. Okay. अभी इसमें this is something which is called as malogary. Okay. इसमें as I told, we are going segmentally, but we plan to go for fixed treatment only. Fixed में आपका एक treatment आता है जिसको बोलते हैं all on 4. Okay, 4 implants will take the load of complete arch, but they have to be placed strategically. Okay, so this guide, this is a reference guide which helps you there. So now what we have done is I have first fixed the malo guide intraorally, then posterior implants I am placing at an angle. Okay, क्यों एंगल पे डाल रहा हूँ? सीधे क्यों डालते? एक तो नर्व आगे प्रीमोलर के पीछे में, तो लेंथ कम मिलता है. दूसरा, बोन डेंसिटी हमेशा एंटीरियर मैंडिबल में और हाई होती है. So the all-in-4 tries to take use of both things. When you are placing implants at an angle going behind further, and you are getting advantage of having a grip on the better quality. So 1, 2, 3, 4 implants are placed. Now these are the abutments which are placed over the implant there. I forgot to tell you one step. This kind of situation now, when you are placing all in 4, what is done is we have fabricated a complete denture first. Okay, not inserted, but we made a complete denture because we wanted to give the process on the very same day. ठीक है, जिस दिन इम्प्लांट हमने पेशेंट आया, कोई वेटिंग पीरियड नहीं रखना है. नॉर्मली इम्प्लांट में वेटिंग पीरियड आता है ना, हीलिंग का पीरियड आता है 3 मंथ 6 मंथ, इसमें नहीं आता है. इसमें आपका हमने पहले कंप्लीट डेंचर बनाया, सर्जरी किया, मल्टी यूनिट अपार्टमेंट्स अटैच किए, रेडियोग्राफी के लिए चेक कर लिया, सब कुछ ठीक है. These are temporary cylinders. ये पहले का बना हुआ डेंचर है मेरा, जो मैंने पहले बना दिया. ठीक है, डेंचर को सेम डे पे सर्जरी के बाद में इमीडिएटली कन्वर्ट किया और इट इज फिक्स्ड इन. अब ऊपर का कंप्लीट डेंचर दे दिया, नीचे का तो ऑलरेडी गिवन फिक्स्ड. पेशेंट इज वेरी कंफर्टेबल कंपेरेटिवली. ओके, एनी डाउट है? दिस क्लियर? This is a provisional process. Okay, this is not a final process. That will be changed. Okay, same you can see in this situation. Here a final process is also given. So I want to show you people. Now this patient is having, this is maxillary features. Maxilla, most form teeth are, natural teeth are there. Posteriorly, RPD is there. But mandibular is edentulous. Now the patient was having fixed. So again, अच्छा. लास्ट में क्या किया था? आई यूज्ड मालो गाइड. हियर वो यूज द गाइडेड प्रोसीजर. सीबीसीटी के बेस पे हमने गाइड बनवाया था. विद दैट वी डिड, वी प्रैक्टिस द फ्लैप, डिड द बोन प्लेटनिंग एंड वी आर फिक्सिंग आवर स्टेबलाइजिंग आवर गाइड. गाइड को स्टेबलाइज किया, गाइड के थ्रू ही ड्रिलिंग, गाइड के थ्रू ही इम्प्लांट्स दे विल गो. ओके, जहां पर भी आपका बोन डेफिशिएंट नहीं है, दिस इज वेरी यूजफुल. ठीक है, अच्छा वन थिंग, इसमें कोई ठीक है, कोई क्वेश्चन इसमें और क्लियर? नो कंफ्यूजन? व्हाई आर यू नॉट लिसनिंग टू मी, माय स्टूडेंट स्पेशली? भाई फर्स्ट में मैंने आपको बताया था कि जब फ्लैपलेस कर रहा हूँ तो उस टाइम तो फ्लैप गाइडेड कर रहा हूँ तो फ्लैप नहीं खोला था ना उसमें मैंने, तो यहाँ पे खोला है ना फ्लैप. क्या इतना बड़ा फाइंडिंग मिस कर गया पूरा? फर्स्ट में तो मैंने बोला था फ्लैपलेस है, तो यहाँ फ्लैप क्यों खोला? स्पेशल रिक्वायरमेंट वाज देयर कि इसमें the bone was uneven, it was unevenly contoured. If we had placed through guide, it would not have succeeded. So initially only we did planning that we will plateau the bone, plateau करके उसको नीचे लेके जाएंगे. From the point where we will get the stable bone, from that point onward we will start drilling. Okay, hence this is a bone level guide. The first picture I showed was a tissue level guide. ठीक है? Again, denture was prefabricated, lower denture as a requirement. All are parallel to each other. Converted, this given on the very same day. ठीक है? Same day patient को they got their teeth. Now patient was given this and was told to come after 3 months. Normally implant को loading 3 months बाद करते हैं. इसमें 3 months तक he was having a provisional denture with them, right? After 3 months, patient came again. So again the steps. These are impression posts. We verified radiographically whether they are fine or not. कोई gap तो नहीं है. We splinted them. Splint करके made the impression. Why splinting is needed? देखो, this has to be a joint processes now, है ना? जब प्रोसेस को ज्वाइन कर रहे हो, मेटल आपको बिल्कुल भी प्ले का जोन नहीं देता है. अगर 0.1 मिलीमीटर का भी डिफरेंस है, it will not see it. They can see it. All 4 can see it only if they are precisely in the very same position. A slightest shift during impression making, cast or in any XYZ area will lead to a faulty structure framework, it will not seal. That's why splinting jig verification is essential, right? So now this is the final processes. Now this is a PFM processes and cemented into patients. Now, got it? पहले ये का था रेडियोग्राफिकली यू कैन सी 4 इम्प्लांट है, पूरा उनके ऊपर में जॉइंट प्रोसेस है, पेशेंट इज हैप्पी, फ्री ऑफ कॉस्ट, करेक्ट है? अभी क्या फीलिंग आ रही है? इनफ इज इनफ, बस करो, हाँ? सो थैंक यू एवरीवन, थैंक यू.
कर देना. हाँ. Thank you so much, Manish sir. Moving forward to our next speaker, we have with us Dr. Ashish Bali sir, who completed his masters from Himachal Pradesh University and is working as a reader of periodontist and implantologist. I would like to request sir to address the gathering on his topic, periodontal plastic and aesthetic surgery. नहीं सर. आगे से.
My voice is audible. Is it fine? Am I audible at the last?
Not done, sir.
Understood? So mainly if I will tell, I will not go into all those details, but just for the sake of introduction I will tell you what is aesthetic. So whenever we are talking about aesthetics, so mainly it is not like you give a very good natural Emax crown or you give a zirconia crown. It is not, we cannot call it as aesthetic. Whenever we are talking about aesthetics, so all the three components, your lip line, your teeth and your soft tissue, that is the pink zone. So all the three components should be in harmony to each other. Understood? Whenever we are talking about anything that is, we tell okay it is aesthetic. So aesthetically pleasing means whenever a patient is smiling, so all the three components, that is your soft tissue, that is your lip line, and then the most important is your teeth. They all should be in a harmonious position to each other. In order to make a person look good, or in order to make a person, he will tell you, okay, I will charge you 50,000 or 30,000 and I will place a dental implant. At that point of time, if recession will be there, so then he will be behind your head. Why the recession is there, why that abutment is visible, or why metallic hue is there. So at that point of time, or in a even if patient is not noticing all those things, we as a good clinician, we cannot afford to do all those things in a aesthetic concerned area. So that is why all those things need to be taken into consideration before doing any type of surgery. So whatever any type of aesthetic correction, either in case of your dental implants or in case of your natural tooth, all these things we will categorize under perioplastic surgery. Normal recession coverage, any augmentation around implants, all those things are there. Then crown lengthening, it is a very famous procedure, might be people have also heard. Whenever we want to give a prosthesis on top of a tooth and we don't have a good amount of tooth structure, so we will not be able to get that retention and resistance form. In order to make a prosthesis stay there, we need a certain amount of height of that particular tooth. So in order, whenever we don't have that much of space, or whenever we don't have that much of height, so in order to place a crown, we have to go for a aesthetic crown lengthening. Or in certain patients you have seen the developmental defects are there in which like congenitally small teeth are there. Like anodontia is there, anodontia you have heard, absence of tooth is there, peg shaped lateral are there. Similarly, we have congenital defect where usually the patient will be having a smaller tooth and a big gummy smile. So whenever a patient is smiling, so a big gummy smile will be there, more amount of gingival pink tissue is visible and a small amount of white teeth is visible in that particular smile. Understood? So in perioplastic surgery we want a balance of, or whenever we are talking about aesthetics, we want balance of all these three things, as initially only I have told you. So that thing also I will tell you few later on slide, I will tell you. Then we have aberrant frenum, orthodontic treatment, we go for orthodontic treatment. So before orthodontic treatment or after orthodontic treatment, whenever a patient is having a high frenal attachment, so just because of a high frenal attachment, patient will be having a big midline diastema. Understood? Like your Nikhil Verma sir has also shown one case he was showing, so later on he has covered that midline diastema with nice crowns. So that is also one of the treatment, but whenever a patient is going for orthodontic treatment, a young patient is going for orthodontic treatment, so the orthodontist don't want the same thing to happen again. So in order to minimize the relapse, we have to go for frenectomy procedure, frenectomy or frenotomy. So whatever high frenal attachment is there, we want to remove that attachment. Similarly, we have different categories of frenal attachment, that is mucosal, papillary, gingival, papilla penetrating. Also those classification will be learned by you in subsequent years whenever you will go in final year in terms of PG. But at this point of time, you need to understand whenever we have a high frenal attachment, so we want to remove that high frenal attachment, which will be giving pull, and later on it can cause a relapse in an orthodontic case. Then we have this thing, socket preservation, augmentation of a dental is one of the very famous things nowadays. Socket preservation, why we want to preserve the socket? Because nowadays as implants are going in trend, so we want after the extraction, I want a good amount of bone to be there, so that later on I can put the implant there. So at the time of extraction only, conservative extraction is also required, but at the same time if you will put a artificial substitute in that socket. So the anatomy of the socket will be preserved. Understood? Later on, after 3 months, whenever you will recall that patient, so you will get a nice bulge of bone where you can easily put a dental implant. So socket preservation is also there. Then ridge augmentation is also there. Ridge augmentation, whenever you want to place a dental implant, like I want to place a dental implant in the posterior zone. So, but as sir has also told you, shown you so many pictures where we have inferior alveolar nerve and we have to take the height. We want a sufficient amount of height so that we can put an implant. But we are not, we don't have a bone there. So we need to augment the bone. So augmentation, horizontal augmentation and vertical augmentations are required. Horizontal augmentation means we are doing augmentation in a horizontal manner where we are actually expanding the ridge width. And vertical augmentation means wherever less amount of height it is there, we are increasing the height of the ridge. So all these procedures are categorized in the perioplastic procedure. So now the objective, again if you will see here in this diagram, you can see recession. Gingival recession is also there in this anterior tooth. Again, correction of this procedure is categorized in the perioplastic surgery. Then we have a shallow vestibule. Shallow vestibule means we don't have a sufficient amount of keratinized tissue. So you see these muscle fibers will be having a continuous pull on these molars. Because we don't have any keratinized tissue, your mesial junction is till here, your marginal gingiva. So it will cause a continuous pull. Understood? So in order to, because here if you will see in molar area, gingival recession is also there. Understood? So sometimes it is because of some pathology, sometimes it is because of the pull from these aberrant fibers. So in order to minimize gingival recession, we have to augment a zone of keratinized tissue. Understood? Then later on, see, this is aberrant frenum. So whenever we have aberrant frenum, we want to do frenectomy, we want to remove this frenum in order to prevent the relapse of orthodontic treatment. Then we have a aesthetic surgical correction whenever exposed root surfaces are there. That is also dealt by perioplastic surgery, and the most recent is tissue engineering. So now, before doing any type of surgery, we have certain prerequisites. We need to fulfill few criteria before doing any surgery. So the first and the foremost criteria as far as perio is concerned, we always look for a minimal amount of plaque or minimal amount of calculus. Why we want minimal amount of plaque or minimal amount of calculus? In order to minimize the inflammation. Because if a surface is inflamed and you are trying to do any type of aesthetic, these procedures are very technique sensitive, very technique sensitive. And in order to get a very precise or excellent results, we need to have loops also. We need to, the entire armamentarium is different for in order to achieve a good result. Although you can attempt with the normal instruments also, but in order to get a very precise and a very good plastic or aesthetic result, we need to look for a good loop. We need to look for a 6-0 or 7-0 suture material, very thin, very small suture material. Then we need to have those microsurgical handles for holding these very thin suture. So all those other armamentariums are also required in that type of thing. So criteria I was telling you, we don't want any type of inflammation. We need absolutely normal tissue in order to do any type of surgery. Because if any inflamed tissue is there and you will try to give an incision, the inflamed tissue will have a tendency to move. So you will not be able to give a very precise incision. Understood? But whereas how our perio surgeries are different from oral surgical procedure is that our surgery we want a very good precise thing. A very microsurgical level of instrumentation it is required. Otherwise, in the inflamed area also you can give an incision, but you will not, the incision will not go in a single direction. It will go like this. So we don't want all those things to be happening in perioplastic surgery. So inflammation should be very minimal. Then we need to understand about the anatomy. So in the perioplastic surgeries, basically I want you people to understand. You have understood what is thin gingival biotype, what is thick gingival biotype. Whenever we have thin gingival biotype, so in order to make or in order to convert the thin gingival biotype into a thick gingival biotype, we need connective tissue graft. So two type of grafts are there. You try to understand. We have two type of graft. One is your free have a thin biotype. So we need to augment. I want that thin biotype to be converted into thick biotype. Why I want a thick biotype? Because if I would have a good amount of keratinized tissue, good thick biotype, so always these good thick band of tissue will prevent the spread of inflammation. It will help in maintaining the health of the peri-implant tissue or around the tooth, whatever tissues are there. So it will always help in preventing the spread of inflammation. So that is why we always like, or we always want to have a good amount of keratinized tissue. Understood? Keratinized tissue or attached gingiva, you know all those things. Huh? So we are concerned with that thing. So one basic requirement is we want minimal inflammation. We want no plaque in that particular site where you want to operate. Then we need to understand about the anatomy. Whenever we are talking about the attached gingiva, you just subtract the marginal gingiva, the tissue which we are left with, we can call it as attached gingiva. So this nice band of keratinized tissue is very important, very important. Whenever we want to do any surgery or any implant placement, anything. Why? What is the advantage of having this nice band of keratinized tissue? Is minimal amount of plaque accumulation will be there. Patient will be able to maintain his or her oral hygiene. Then aesthetics are good. Spread of inflammation is minimal. Then this good keratinized band of tissue will help in withstanding the masticatory forces also. So that is why we need a good amount of keratinized tissue. So whenever we have a less amount of keratinized tissue or less amount of keratinized gingiva, either around implants or either around your natural tooth, we will be having more amount of inflammation. Spread of inflammation will be more. Chances of gingival degeneration will be more. So that is the unique thing about attached gingiva or keratinized tissue. So that is why we are so much concerned about the keratinized tissue in the periplastic surgery. And this keratinized tissue is also having a role in various type of aesthetic surgery. So that is why we are concerned about. So gingival recession, if you will see here in this tooth, if you will see, try to see. So we have a canine with a good amount of gingival recession. The entire root surface area is visible, if you will see here. So now what we can do is we have to correct this condition. Patient will be having aesthetic concern, patient will be having a sensitivity concern. So we have to cover this exposed root surface. So either we will be using mostly gold standard is connective tissue graft for recession coverage. And we have, I will tell you, in those patients where they don't want to get a secondary surgical site, in those patients we have a commercially available graft also. So we have a substitute of connective tissue graft also, and we have a substitute of free gingival graft also. So that also I will tell you in subsequent slide, but here you try to understand. See, this is a gingival recession area, so now we want to cover. So we have a different type of procedure, different classification, different set of procedure. So just I will name it for you and quickly show you all those photographs. So we have a pedicle type of flap and we have a free flap. So what is the difference between a pedicle flap and what is the difference between a free flap? Pedicle is nothing. Whenever any sort of graft which is attached to one end, we can call it as a pedicle flap. Understood? And whenever the entire chunk of tissue is taken it out, so we can call it as, if from the palate area, if I will try to take out a graft. So from palate I am taking out that graft and I am putting it in a mandibular anterior region. So that graft which I have procured it from palate, we can call it as a free flap. Free flap or free graft means it will not be having any blood supply from the adjacent area. While the other thing we can call it as pedicle. Pedicle means it is adhered, it is attached to, one end is attached from the adjacent tissue. I will show you in the subsequent slide. Here you try to understand, like we have a pedicle flap, we have coronary advanced flap, then we have regenerative procedures, we have so many other modifications. You try to just see all those photographs I will show you. So you have understood, so far so good, or it is going overhead. Overhead transmission is there. Okay, later on also you can come to department and then I will tell you few things. So we have, for third year we have learned one classification, Miller's class 1 gingival recession. So we have a Miller's gingival class 1 gingival recession. Shallow, narrow, shallow, wide also we have studied. So we have a shallow and narrow type of gingival recession. So how I can treat this gingival recession? So we have a pedicle graft I have told you. So we have a lateral pedicle graft. So what I will do in case of a lateral pedicle graft, I will give a vertical incision there and I will try to mobilize this tissue to the recession area. Understood? Pedicle means Here you can see here in this diagram, if you will see, if you will try to see. So now you will be having an idea what is pedicle flap and what is a free flap. Pedicle means, if you will see here this tissue, so in this diagram what we have done is we have given a vertical incision. But the main prerequisite of doing the pedicle flap is we need to have a good amount of keratinized tissue in the adjacent side. Whenever I want to move a pedicle, so in order to move a pedicle, I will be having a good amount of keratinized tissue. See here, we will be having a good amount of keratinized tissue. So this keratinized tissue is utilized in order to cover the receded root. So here I will give a vertical incision, and here you can see a pedicle is moved, and later on you see a nice recession coverage is achieving. Understood? So pedicle means whenever you are rotating a flap, so this pedicle will be having a blood supply from the area beneath it. So the pedicle is remain attached. Whereas in case of your free graft, it is free, it is not attached from any area. So pedicle flap is also used in correcting single tooth recession. Single tooth recession with you will be having a good keratinized tissue in an adjacent zone. So we can utilize pedicle graft. Along with pedicle graft, if you want to make the tissue thick biotype, so you can add either commercially available soft tissue substitute, or from the palate you can take out connected tissue graft. Understood? So this is also, now this is another technique. In another technique, this is a double pedicle or double capilla flap. So in this technique also you see we have a gingival recession in the canine area, and how I will be correcting this recession, I will move one pedicle from this side and one pedicle from this side. So see, I will be giving a one vertical incision in this direction, one vertical incision from this direction. Two flaps are raised, and these two flaps are mobilized in the middle. So here you see the two flaps are mobilized in the center, and the recession area is covered with two pedicles. Initially, we will be using one pedicle. So now in this case, we are utilizing two pedicles. One from this side, one from this side. So two pedicles are united in the center, and we have achieved a nice recession coverage. Here also clinically you can see. Here we have a gingival recession in this area, but the adjacent area will be having a good amount of keratinized tissue. So what we can use is we can move two pedicles. Two pedicles we will be moving in the center direction, and we are actually getting a good amount of result. Here also you can see good amount of, this is the pre-op and this is the post-op. You can see good amount of recession coverage is achieved. So nice band of keratinized tissue. Then we have a coronary reposition flap. Coronary reposition flap is also one type of flap. The main area or the main indication of coronary advanced flap is whenever, like pedicle flap I have told you now, whenever you have a single tooth recession, so mainly we will go with the pedicle flap. But whenever we have a multiple, I have a multiple gingival recession in the maxillary area. So from where I will move the pedicle? So now in such type of scenario, we will be going with the coronary advanced flap. But you should again will be having a good amount of keratinized tissue in order to advance the flap. So similarly here they have shown it in a single tooth, but again the main single tooth also you can use coronary advanced flap, but mainly it is used in cases of multiple gingival recession. So whenever I will be having a multiple gingival recession in all these teeth, so I will give two vertical incision and the entire flap is mobilized. The entire flap is mobilized in the coronary direction, and all the receded root areas are covered with that thing. But again, one thing you have to keep into consideration whenever you have a thin gingival biotype. So at the time of advancing that coronal flap, if you will put connective tissue graft beneath that flap, or if you will put an artificial substitute, then it will be good for you, because in thin biotype, if you will try to advance that flap, the thin biotype is very thin, it is very fragile, it will be having a tendency to go back into its normal position. Wherever in case of thick biotype, it will be there in that new position. So try to place any bone substitute, soft tissue substitute, or the gold standard connective tissue graft. Understood? Then we have one more technique, we can call it as semi-lunar technique. It is also mainly utilized in case of a single recession area, very mild single recession area. So here what we can do is, here this much amount of recession is there, I have a good amount of keratinized tissue. So what I will do, I will give a semi-lunar type of incision. So semi-lunar type of incision is there. So see, this entire band of tissue is mobile now. So now what I will do, I will coronally advance this mobile band of tissue. Understood? So what we are doing is, we are actually giving a semi-lunar type of incision, and then we are trying to advance this soft tissue. So here you can clearly correlate. This is the pre-op and this So this is also one type of technique. Then this is your what I was telling you na, in cases of multiple gingival recession. So see in this picture you see we have a multiple exposed root. So here we are doing the coronally advanced flap, means we are advancing the flap from a coronal direction and we are trying to cover these exposed root. But just because we are having a thin amount of thin biotype, so I will be putting a connective tissue graft. Here in this diagram, this is a connective tissue graft that is harvested from the palate. So beneath this flap, I will put this connective tissue graft. So this connective tissue graft will be placed onto these exposed root surface, and then the flap is coronally advanced. Here you can see the flap is advanced in a coronal direction, and beneath that flap, I have put this connective tissue graft in order to get a good bulb. So see, very nice result you have obtained. See, this is the pre-op and this is the post-op. Post-op, you can see a good band of keratinized tissues formed on the exposed root surface, and it is much stable. So we have achieved the bulk of tissue also, and we have corrected the gingival recession. So that is also one of the techniques. So this is one example, one case very important I want to show it to you all. See here in this tooth anterior region. So if you will see here in this tooth, we will be having a metallic hue. Why we will be having a metallic hue? Just because we are having a thin gingival biotype. The tissue is thin, so it is in an aesthetic zone. I have placed a noble bioware, very costly implant. I have used a peak material to restore the tooth, but still I will be having a metallic hue here. So if a young girl is there, she will not mind. She will tell why this metallic hue is there. So in these conditions, spread of inflammation, I have told you that whenever the tissues are thin, spread of inflammation will be more. So underneath, at the time of correction, whenever they have raised the flap, a good amount of bone loss was there in the adjacent area of the implant. Why good amount of bone loss is there in the implant? Because the tissues are very fragile. So whenever the tissues are fragile, the spread of inflammation will be more. So here we can clearly appreciate a good amount of bone loss. So now what we will be doing, how we will be correcting this condition, we will be putting a bone graft, either artificial bone graft or the autogenous graft. We will be trying to put these bone graft in this area, and then we will be trying to cover this area with the help of a GTR membrane. This membrane we will be putting on top of to this exposed area. So we will be getting this type of result, post-operative result. Now we have covered this defect. We have achieved the augmentation, bone augmentation we have achieved, but soft tissue augmentation till now we have not achieved. So see here at the time of second stage surgery, when we are putting a gingival former here, at that point of time again I have put a connective tissue graft. So here you can clearly appreciate. Here you can see this is your gingival former. On top of the gingival former you can see we have placed a connective tissue graft. So here you can see, now correlate this picture and this picture. This picture, above the gingival former, I will be having a good amount of keratinized tissue, whereas in this area, very thin, very fragile tissue was there. So post-operative result, if you will compare here and here, so this is, I believe, this is more acceptable to the patient. Nice. That is the thing initially I have told you now. So in perioplastic surgery or in case of whenever we are talking about aesthetic, it should be a balance of between your white structure, pink structure, and the lip line. So all the things should be taken into consideration. That is not lip line, but two things should be taken into consideration, that is the pink soft tissue and the white tooth structure. Understood? So that is why in case of implantology also, nowadays we always talk about the prosthetically driven implantology. That is very right thing to do, but we should be while placing or while doing anything, at least soft tissue should be also taken into consideration while doing all those things. So this is again one of the technique, tunnel and pouch technique. See, this is connective tissue graft. This is we have taken or we have procured it from a pallet. So this is also one of the type of technique in cases of multiple gingival recession. So here we are making a tunnel. Tunnel, you know what is tunnel. So just with the help of a periodontal knife, we are making a tunnel, and beneath that tunnel we have placed this connective tissue. So inside the tunnel we have placed the connective tissue, and we have tried to advance the flap. So see again, if you will compare, see this is your pre-op and this is your post-op. Understood? So post-op, again you see a nice band of tissue that is formed onto the exposed surface. Here we can clearly appreciate a good amount of recession. So that's also one of the technique. So this is free gingival. Again, this is for implant patient I am telling you for implantology. See here, if you will see here in this first picture, a nice bar has been prepared by people. But again, if you will see in the apical area, we are not having good amount of keratinized tissue. Your this thing, your mucogingival junction is near to your this thing, near to the area of the bar. So the chances of or here those people, those who know this roll test, we always tell you, tension test, roll test. So this is roll test only. So with the help of the probe, we are actually doing roll test and we are seeing how much amount of keratinized tissue is there. So see here we will be having a very deficient tissue. So we want to augment that tissue in this area. Why we want to augment that tissue? Because if this much amount of tissue will be there, so the chances of spread of inflammation will be more. The chances of the success rate, we cannot guarantee in this situation for how many years the implant will be there. Might be 3 years, might be 4 years. Otherwise, if we will be having a good amount of keratinized tissue, so might be 10 years will be there, or 12 years will be there, or 20 years will be there. Because the healthy tissue, the more healthy amount of tissue will be there, it will be easy for the patient to maintain the hygiene also, and it will also prevent all those masticatory forces, spread of inflammation will be more less, and it will be easy for the patient to maintain. So freeze gingival graft, see this freeze gingival graft, we have procured it from pallet. This is strip technique. So these nice strip of freeze gingival graft we have procured from pallet, and here we have placed. Here also we have placed. So see, now you try to compare only the pre-op and the post-op you see here, or for that matter, see this picture. We will be having a minimal amount of keratinized tissue. But here, if you will see, I will be having good amount of keratinized tissue beneath the bar. So this is the pre-op, this is the pre-op, this is the post-op. So this is a more favorable condition. Understood? So this is also one of the areas here. Here you can also see in this picture, your mucogingival junction will be at the level of your tooth or at the level of the prosthesis. So now I want to augment a good amount of keratinized tissue here in this area. So I will give a incision in the horizontal direction. I will open up this flap, and this is also one free gingival graft. This free gingival graft is procured from the pallet, and we have placed this free gingival graft. So again, now you see this diagram and this diagram. Understood? Here you can clearly appreciate here, if you will see, the nice band of keratinized tissue is formed here. If you will see, from here to here, if you will see, a nice band of keratinized tissue is there. But if you will see in this diagram, we will be having the alveolar mucosa only. This is all alveolar mucosa. This is all free alveolar mucosa. This is fully mobile. So this condition is more favorable to me. If you will talk, this condition is more favorable to me. So 1, 2, 3 videos I will show you, and then I will stop. I will show you one video about the artificial substitutes which we will be having for free gingival graft and connective tissue graft. Which is the company. So this is mucograft. So again, see this video, then I will tell you. So this video again we will be having a less amount of keratinized tissue here in this side. So see how we are augmenting the socket.
इसका वॉल्यूम बढ़ा दे.
So seeing this, this is all videos. See, it is very easy thing to understand, and you will enjoy. So see here in this picture, we are actually trying to augment the keratinized tissue. We will be having a see how the partial dissection has been done. All these surgical techniques will be learned by you people in case of in your final year. That time it will be easy for you, but at this point of time you try to see now see how we are actually procuring this free gingival graft. So I have told you, see, from the palate they are trying to see. So epithelium along with the connective tissue they are trying to take it out. So I was telling you about free gingival graft. This is a strip technique. So this is a strip of free gingival graft. So they have procured it from palate. So now they are trying to close the donor side. So initially I have told you about the anatomy of donor side and the anatomy of the recipient side. So now see here in recipient side, he is placing your strip of free gingival graft in the apical area, and later on the rest of the tissue is augmented with the help of artificial substitute. You try to see. So this strip is placed in the apical area. So still I will be having this exposed area. So this is my muco graft. Understood? This is substitute for free gingival graft. This is sold by Glycine India. So see here in this condition, the rest of the exposed, because we cannot take this much amount of tissue from the palate. So we have tried to take a thin strip of free gingival graft. We have put it in an artificial, we have put it in a apical zone, and later on the rest of the raw tissue is covered with the help of a artificial membrane. So again with the help of resorbable suture they have covered the surgical site. So see how much stability they have achieved post-operatively. So now if you will see such type of patients post-operatively, see nice amount of keratinized tissues here. See how much amount of keratinized tissue we have achieved. So now in this condition, if I will place an implant or anything I will do, so I can tell patient, okay, it will last for 5 years, not 5 years, more than 5 years, 10 years, because this much amount of keratinized tissue is always be beneficial for the patient, always be beneficial for implant, success of implant, because the spread of inflammation will be less, it will also help in withstanding all those masticating forces, so that is why it is very important. So see, this is the difference between your two mucograft and fibroguide, between your commercially available free gingival graft and commercially available. See this video. This is free gingival graft. Mucograft means free gingival graft.
Excuse me, you certainly cannot talk about soft tissue regeneration without
So this.
Hi there, I am Bishop Fibroguide.
This is the fibroguide. This is the newly invented thing. Last year only came into Indian market. This is a substitute for connective tissue graft. In those patients, very rich patients who don't want any secondary surgical site, in those patients I can buy this Glycine fibroguide, 20,000 rupees in Indian market. So you can use this also. So these two things are there.
Does not mean I'm not scientifically based. I have quite a number of publications in the market too. My structure is porous also, but my collagen is smart Croxley, which gives me a little bounce.
So the structural variation they are telling what all, how these two things are different from each other.
Well, I offer clinicians an alternative to the connective tissue graft, allowing them to gain soft tissue volume, especially around implants.
Okay, so we've established that difference.
Exactly. Plus, we both eliminate the need for a second surgery, and both of our healing looks great.
Tell me more about me.
Or me.
So these two things are commercially available. One is your Glycine fibroguide and one is your Glycine mucograft. So these are the two artificial substitutes for your free gingival graft and mucograft. Whenever you want to augment the tissue, go for these substitutes. In those patients, those who are actually rich or those who can afford. So then correction of excessive gingival display. I was telling you. See, this is one of the again clinical pictures and photographs only. I am telling you. I have no theory. I am telling you. Here in this picture, again I was telling you in the initial, there should be balance between the pink and the white tissues. So here we will be having an excessive amount of gingival display. So commit smile will be there. So we have done aesthetic crown anthems. So here in this post-operatively you can see initially we whatever amount of the height of the incisor will be more post-operatively because we have done aesthetic correction. Aesthetic correction we have taken out this thing. Good amount of keratinized tissue we have removed. So this is aesthetic crown anthening. One video I will show you. Try to see this video. This is smile designing. This is only crown anthening along with the veneer which we have placed. See this video. See, so in this patient also we will be having a small teeth. See, very small teeth. So see, while smiling she will be having a gummy smile. So now how we will be correcting this surgery. So see how much small tissues are, small tooth are there at the time of smiling. See. So now we want to correct this thing. So this is how much amount of increase in the height of crown we want. So this is the mock. So with the help of backs up and all those things, we are actually looking for how much increase in the height of the crown we will do. So this is again, see, this is crown lengthening. Aesthetic crown lengthening where we have removed a good amount of soft tissue. So the height of the clinical crown is more. Understood? Initially it was very small amount of crown. Now you see. So apart from doing this smile designing, in this crown lengthening we have placed veneers also. So these are the veneers. So see, this is the pre-op, this is the post-op. So post-operatively you can see a good amount of balance is there between the pink tissue and the white teeth. So see, this is the pre-op, this is the post-op. This is gummy smile. So now you can see correlate the pre-op and the post-op. So now how beautiful she is looking. See. So this is the pre-op condition, this is the post-op condition. Clearly you can correlate. So see how much amount of gummy smile was there in this while here you can see. So this is more acceptable, I guess. Understood? So all these procedures are very important. Again, more things I will tell you, I will not take much time. One is the vestibular deepening. Initially or only I have told whenever we will be having the shallow vestibular depth. So in those cases, apart from doing augmentation, we also do vestibuloplasty or vestibular deepening. And frenum, frenotomy and frenectomy I have told you in order to prevent the relapse after ortho treatment we do frenotomy or we do frenectomy. So different type of techniques are there, but I will not tell you because already so much of time is there. So see, then last of all, this papillary reconstruction I just want to tell you. So in few conditions you have seen such type of patients also. So in these patients, what we actually do is we never try to cover these all black triangle with it. Sometimes we try to cover it with the help of a crown also, but actually we can correct all those conditions with the help of a connective tissue graft. There also you can utilize. See, this is the model. So here in this condition also you see the clinical picture. We have given semilunar type of incision and we have taken a connective tissue graft from the palate, and here in this diagram you see from this semilunar incision we have put that connective tissue graft inside. Or for that matter, if we don't want to use the connective tissue graft, we can buy that fibroguide from the market, and we can put that fibroguide here, and nice correction it is there. See, this is the pre-op, how much of amount of defect was there in this interdental area. So good amount of receded papilla was there. So here post-operatively you can see. So that is the comparison. So papilla field is also there. Then this is small, this is very recent tissue engineering, I will not tell you. Three things are there: signaling molecules, cells and scaffolds are there. So these three things unite together and we will be going for tissue engineering. Last of all, we will be, I will show you, this is ridge augmentation. This is ridge augmentation or this is your socket preservation. Initially, I have told you about all those things. So after extraction, we usually put artificial substitutes or the autogenous bone grafting, all those extraction socket in order to get that good bulk of ridge for post-implant placement. So gingival depigmentation is also one of the very known procedure. So in this type of patient also we do depigmentation. That is also one of the aesthetic procedure. So I cannot I cannot actually finish the entire topic in half an hour, but I assume that most of you have understood. Not if at all, not 50%, at least 10 or 20% of the procedure. So whenever you will come back in final year or intern or those who will take PG in perio, so definitely we will try to help it out. So that's it. Any questions? That I was aware of.
Thank you so much, sir. It was wonderful session. Now I would like to invite Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir and Dr. Yash Sharma sir to felicitate our speakers. Now I would like to invite Dr. Ashish Bali sir on the stage. Many congratulations, sir. Now I would like to invite Dr. Manish Chadda sir on the stage. Many congratulations both of you. Congratulations, sir.
Swarnam?
Yeah, sir.
Moving forward to our next speaker, I would like to call Dr. Malika Sethi on addressing our dais to the topic lasers in dentistry.
Now you can start.
Well, good evening, ladies and gentlemen. It is a matter of great pride and proud privilege to be a part of the prestigious Second World Dental Science and Aesthetics Conference. At the very outset, I would like to thank the organizers, especially Dr. Ashish and Dr. Anmol, for giving me this opportunity to be here today on this platform. I am Professor Dr. Malika Sethi Rishi, Faculty Laser Dentistry at Universidad del Gran Rosario, Argentina, and Director at Gamzo College, Gurgaon. Well, laser is one of the most captivating technologies which has revolutionized several areas of treatment in the last few decades. And we all know we are moving from steel age to laser age. So today I would be deliberating on the topic laser focused, bringing art to surgical periodontics. Before I go into the detail of perio and surgical periodontics, just a little basics about laser. So when laser strikes the tissue, it can either be reflected, absorbed, scattered, or transmitted. As far as the absorption curves of different dental compounds by various wavelengths is concerned, As you can appreciate here, the shorter wavelengths, that is the wavelength which lies between 500 to 1000 nanometers, are readily absorbed in pigmented tissue and the blood elements. The diode and the Nd:YAG, they have high affinity for melanin and less interaction with hemoglobin. The longer wavelengths, especially the carbon dioxide and the erbium family, that is the erbium YAG and the erbium chromium YSGG, they are more interactive with water and hydroxyapatite. When laser exerts different tissue effects, it can be photothermal, photochemical, photovaporolysis, and biostimulation. So carbon dioxide and the erbium YAG, they exert a photothermal effect. Now, what is photothermal effect? The name suggests conversion of light into heat. The Nd:YAG and the diode, they create a condition that is known as the hot tip effect. So basically, the tissue is vaporized or coagulated by the overheated tip rather than the laser energy itself. Now, if we look at these different tissue temperatures, the various observed effects are as follows. At 37 to 50 degrees, hypothermia takes place. At 60 to 70, coagulation and protein denaturation occurs. At 70 to 80 degrees, welding takes place. At 100 to 150, vaporization and ablation, and at more than 200, carbonization take place. Now, the temperature, if it is raised to more than 200, that means it is detrimental to the tissue, as you can appreciate here. Now, talking about lasers in surgical periodontics. So, what is the rationale for therapy? Why do we need to incorporate lasers in surgery? Firstly, it helps in root surface decontamination and detoxification, results in targeted reduction in subgingival as well as eradication of pigmented anaerobic gram-negative bacteria, allows for suppression of inflammation, periodontal regeneration, and helps in biostimulation. So biostimulation is basically acting at the molecular and the cellular level where increased amount of ATP synthesis is there, increased collagen synthesis, and it is applied to various and rather every field of dentistry. Well, I would walk you through various clinical cases. Now, firstly, talking about lasers for soft tissue surgery. So what is the effect? If you look at this microscopic picture, the erbium YAG laser results in minimal coagulation, whereas no carbonization, as you can appreciate here. The carbon dioxide results in severe carbonization, whereas a thin coagulation layer is formed. The Nd:YAG results in a thick coagulation layer with moderate carbonization. The diode is said to have the greatest coagulation out of all the lasers, whereas it just offers moderate carbonization. So in short, soft tissues are evaporated or incised, leaving different degrees of thermal denaturation, carbonization, and coagulation. So what is the effect? Basically, laser helps to cut, ablate, and reshape oral soft tissues. It is very, very important to remember that there is no or reduced bleeding, no or less sutures are required. Rather, you don't require any sutures after you do your surgical procedure. There is minimal scarring and wound contraction, allows for greater patient comfort and safety than electrosurgery, less post-operative pain, and very, very less complications. No severe pulpal pain is also reported. Unlike when you use electrosurgery, you end up having severe pulpal pain, which is not there with laser. I'll walk you through various very, very interesting cases. Well, this first case is a case of drug-induced gingival enlargement. The patient is epileptic and is under anti-epileptic drugs for the last 10 years. So external bevel gingivectomy was planned by 3 different methods. The first area, as you can appreciate here, external bevel gingivectomy was done with a scalpel. Electrosurgery was used here. Laser was used here, 980 nanometers, 2.5 watt in contact continuous mode. And what do we see? The initial 7-day healing revealed that the scalpel wounds healed well, this area, as compared to electrosurgery and laser. So the laser area also healed well. But look here, this is the area where electrosurgery was used. Well, it is very, very important to remember, ladies and gentlemen, that Both laser and electrosurgery, they lead to lateral heat dissipation, more with electrosurgery and less with laser. So for such cases of drug-induced gingival enlargement, where both the components are present together, that is the fibrotic and the inflammatory, scalpel is still considered to be the gold standard. Another case of denectomy, we can appreciate the papillary attachment as classified by Plasek in the year 1974. Again, soft tissue with Mason Fotona stain at 400 original magnification, and this is at 6 months after treatment. Now, let me tell you, after each procedure with laser, two important post-operative instructions which everybody should follow. Firstly, no antibiotics are required, just plain analgesics would do. In case of frenectomy, no sutures are required. In cases of depigmentation or gingivectomy, no PAHER, that is the periodontal dressing, is required whatsoever. The patient is very, very comfortable. Just tell the patient, people who are smokers, to avoid smoking, as I said before, for first 24 to 48 hours, and also they should avoid consuming spicy food for at least 24 to 48 hours after the procedure. Important takeaway points as far as periodontal wound healing following soft tissue surgery is concerned. Wound healing, that is primary closure with surgical lasers, is delayed compared with that of a scalpel incision due to collateral thermal side effects, as stated by Sinha et al. In the year 2003. Well, rightly said, lasers are not employed for incision, their target uses being excision and ablation. And in case if you have deeply penetrating lasers, especially for periodontal procedures, we end up having thermal effects, especially on the tooth pulp, periosteum, and the bone. But please remember, deeply penetrating lasers can be applied for tongue and lip tissues because they bleed readily and easily. Now, moving ahead, lasers for surgical pocket therapy. I'm sure you must have understood about lasers for various soft tissue procedures. It is very, very important to remember the practical points. Now, what is the rationale? Why do we need to use laser for a pocket treatment? Well, all of us know there can be challenges to complete debridement and disinfection of periodontal or peri-implant pockets, which range from anatomic complexity of the defects to the patient's inability to maintain good oral hygiene. Secondly, the clinical attachment level and pocket depth produced by initial therapy may still be inadequate for optimum health. Therefore, surgical intervention is required. Well, few cases. A case of laser-assisted flap surgery. Have you ever thought of using laser for flap procedures? Yes, laser can be used as an adjunct. Please remember this word, adjunct, not as a monotherapy. Adjunct to your flap procedures. Well, this case, you can appreciate flap, a mucoperiosteal flap, which is raised here. Now, laser can be used to de-epithelize the undersurface of the flap. So it exerts a GTR-like effect that is prevents epithelial migration along the flap undersurface. In this particular case, laser was set at 1.5 watt in continuous mode. 20-second each tooth was lased. And what do we end up having? This is post-lasing. You can appreciate a light brownish appearance to the tissue, and this is pre-lasing. Just look. Important points, the tip should be kept at an angle of 45 degrees. Horizontal overlapping strokes should be applied. And as I said before, GTR-like effect is created. The epithelium can later be ablated every 7 to 10 days from the outer part of the pocket as well to control epithelial migration. Well, it results in long-term stay. This LANAP is nothing but laser-assisted new attachment procedure where the Nd:ARG laser was used, having a wavelength of 1064 nanometers. And this study was found to have histological evidence of periodontal regeneration, where the authors found out that the mean probing depth reduction was around 5.4 millimeters, and there was a significant amount of clinical attachment gain of 3.8 millimeters after 9 months of follow-up. Various studies have also been done with the hard tissue laser. Well, the recent one, the 2021, with the erbium chromium YSGG was used minimally invasive surgical treatment wherever intrabony defects were present, and it was a 6-month follow-up randomized controlled clinical trial. Important points to remember. Well, laser helps in complete debridement of the defect. Secondly, erbium lasers are said to have They are said to be the most promising laser device for periodontal flap surgery because it helps in granulation tissue removal, tooth surface debridement, and it promotes new bone formation as well. You can use soft tissue lasers also for intrabony defects, and the results are wonderful. Even hard tissue lasers can be used. Only difference is soft tissue lasers are deeply penetrating lasers. Hard tissue lasers, they penetrate just superficially. Moving ahead, lasers for osseous surgery, that is bone removal. Now, if you look at this macroscopic appearance of bone surface treated with carbon dioxide burr and the erbium YAG laser, the carbon dioxide results in visible carbonization. Burr results in a groove with a soft tissue remnant which is attached. The erbium YAG laser also results in a groove but with no soft tissue remnant which is attached. So what makes erbium YAG the laser of choice? Erbium YAG results in precise edges without any thermal damage. We end up having a minimally affected microstructured surface without toxic substances. Now, what are these toxic substances? If I talk about the carbon dioxide, yes, you have toxic substances like the cyanamides and the cyanides. The erbium YAG lasers, they do not liberate these toxic substances. Well, a laser modified layer is formed with the erbium YAG laser, which is said to be mineral rich carbon layer, and it is absolutely harmless. A case of bone graft harvesting, this is the preoperative OPG where the mandibular symphysial region was used as the donor site. Well, this is a recipient site in the frontal maxillary jaw, which is perforated. Now, we have to perforate because it increases the vascularity and allows more growth factors to reach the site. A monocortical bone graft was harvested. You can appreciate the pulse energy, 1000 millijoules. Now, it is important to remember the handpiece is kept at a distance of 10 millimeters from the bone. This is the donor site after block removal. Can you appreciate the edges? They are so precise with the erbium YAG laser, and thereafter it is fixed on and secured with 2 titanium screws. Now, very important. See, I've talked about laser for soft tissue procedures. I've talked about laser for pocket treatment. I've talked about laser for osseous surgery, that is the resective procedure, the regenerative procedure where we can combine laser with flap surgeries and place a bone graft. Now, very interesting is talking about laser assisted flapless crown lengthening. Now, the decision making on the use of laser for crown lengthening is based on the osseous biotype. The hard tissue laser in a closed approach is ideally indicated for a medium gingival biotype case where the width of the osseous crest is 1 millimeter thick, 1 to 2 millimeter of bone is removed, and the laser is fired for 1 to 2 seconds. Now, let me be very clear here. I'm talking about the hard tissue laser here because I'll show you a video after this slide where the hard tissue laser can be used for crown lengthening and you need not open the flap. I'll walk you through 2 more cases where I have used a soft tissue laser for gingivectomy. That is what we do for crown lengthening. Now, when you have a thick biotype, you end up having a trough or an intrabony defect. A thin biotype results in overheating and an unpredictable healing response. So just have a look at this video where flapless osseous laser crown lengthening is demonstrated. We are not raising a flap. Please remember, we are not raising a flap. The first step is sounding and marking the biologic width. It is very important to preserve the biologic width, that is the sum total of the connective tissue and the junctional epithelium. It should not be violated because otherwise we'll end up having inflammation and bone loss. So the first step is gingival ablation with the erbium chromium YSGG. All tissue laser was used. I'm sure you know how do we do crown lengthening. So this is the first step. That is gingivectomy with the scar tissue laser. I'm not opening the flap. Well, I would be needing osseous recontouring also in this particular case, and this laser would serve the purpose for both. So this is gingival ablation with the erbium chromium YSGG. Now, the second step, subgingival osseous recontouring is done. That is, simultaneously bone recontouring is done. I would repeat, I'm not raising a flap. So this is the all tissue laser. And this forms the basis of flapless osseous laser crown lengthening, as the name suggests. So just look at the picture, post-operative photograph of the patient. The patient is a very, very happy patient. Just look at her smile. She's very happy. The front view and the side view. Just look at this. So excessive gingival display, if more than 3 millimeters, is what we call as excessive gingival display, that is EGD. Well, I'll walk you through cases with the soft tissue laser. In this case, BioLaser, that is Epic X 940 nanometer diode laser, is used, set at 0.9 watt in pulsed mode for crown lengthening. Well, this female is a 75-year-old female who reported to me. She was a physiotherapist from Gangaram Hospital, and basically she is a case of full mouth rehab. You can appreciate her OPG very well. Mandibular anteriors were hopeless. We did root canal treatment for all her 6 mandibular teeth. Crown lengthening was done. Now, where does laser help us? Crown lengthening for all mandibular anteriors, 940 nanometers, 1 watt pulsed mode. In this case, composite buildup also had to be done. Can you appreciate the mandibular anteriors? Well, this is after restoration, PFM crowns were placed, and this is at 6 months after treatment. This is a full mouth rehab case where the other areas were also taken into consideration. And she is a very, very happy patient. So basically, I helped her doing crown lengthening. I helped her doing pocket treatment for her. That is a non-surgical pocket therapy. Well, my topic today is laser for surgical periodontal treatment. Talking about non-surgical treatment and surgical treatment, laser bleaching, photodynamic, well, it'll go on and on. So I would limit myself just to laser for surgical periodontics today. Important points to remember. Well, as far as rotary instruments are concerned, they only cut the tissue they come in contact with. Lasers cut to an unknown depth away from the application tip. Well, depth control is rarely an issue. Damage to the underlying tissues may be avoided by adjusting the angle of the laser application tip. Important point, very, very important. Erbium YAG laser should be used with saline irrigation. If not, you end up having thermal changes and toxic substance production. Where laser is said to reduce noise, it eliminates vibration associated with the mechanical cutting and grinding of bone tissue. Therefore, it increases surgical precision and comfort. Now, moving ahead, in perio, we have recession as well. Now, Miller's class 2 gingival recession. This case is a case of laser-assisted laterally positioned flap. I'm sure you must have heard of LPF, that is a lateral pedicle flap. Now, this is an advanced, and this was, actually, this is laser-assisted laterally positioned flap, where laser was used as an adjunct to LPF. Diode laser, this is the original article I'm quoting here, 8110 nanometers at a 3 watt in continuous fashion. Now, the first incision is a vestibular incision, 5 millimeters from the recession, that is the apex of the recession defect. Can you appreciate here in the vestibule? The second is a horizontal oblique incision, and thereafter this flap is laterally positioned onto the recipient bed and sutured. You need not to worry about the area which is here. It will automatically heal. Well, this is the original article quoted by Yilmaz in the year 2014. And this is at 6 months after treatment, where there was a good amount of attached gingiva and reduction in the recession defect. Now, this offers, what is the advantage of using laser? Laser allows for reduced edema, ecchymosis, allows for a passive and relaxed flap. There is maximum augmentation and decreased apical pull. It also stimulates growth factors. Now, I would also like to discuss about low-level laser therapy in periodontal surgery. Well, I've talked about class 4 lasers. We are excising. Laser is used for excision. Now, talking about low-level laser treatment or cold therapy or soft lasers. So basically, the lasers are used for stimulation of human periodontal fibroblast. It reduces pocket depth, plaque index, gingival fluid, MMPs. It exerts an anti-inflammatory effect. There is reduced pain, which allows for stability of the nerve cell membrane, enhances cell revival systems, and allows for ATP production. So everything is acting at the cellular and the molecular level. We are not cutting, we are not excising. This is what is biostimulation, and this forms the basis of low-level laser treatment. Well, important case, the efficacy of low-level laser treatment in the management of intrabony defect. Well, this case is a case of an intrabony defect. You can appreciate here, this is a full thickness mucoperiosteal flap which is raised. The defect depth measurement done with a calibrated periodontal probe. Well, this is one of my favorite cases. So I used laser 0.5 watt for 2 minutes, and the procedure was repeated after 5 minutes for 90 seconds. DFDBA, that is the allograft, was placed here, followed by suturing. Now, after suturing, you can just biostimulate this area on the facial and the lingual side so that it allows for rapid healing. The patient feels very, very comfortable. You can do it after you place the sutures immediately, or recall the patient after 48 hours, and you can do it then also, both on the outer buccal and the lingual flap. So just look. This is the pre-operative, and this is at 1 year post-operatively. Can you appreciate there was a good amount of bone fill which was evident on the radiograph? So laser in this particular case is used as an adjunct, especially low-level laser treatment is used for biostimulation, acting at the cellular and the molecular level, and that is said to regenerate bone as well. There have been umpteen number of articles which have actually the authors have concluded that laser helps to regenerate bone, and you can appreciate here wonderful results at 1 year after treatment. Well, another area where you can use low-level laser treatment is whenever you harvest a free gingival graft from the palate. That is, you encounter profuse bleeding. Now, when you have bleeding, how do you stop bleeding? You cannot suture. You have harvested a free gingival graft, so you can just lase the area. In this case, a 940 nanometer diode laser was used, set at 0.5. This 940 nanometer diode laser being used. Just look here. Post-operative, immediate post-operative. There is good amount of control of. That is what I say is hemostasis. Good hemostasis is achieved. It is only lased for 60 seconds. Now, lastly, talking about lasers and implants. Why do we need to use laser in implant dentistry? It allows for increased hemostasis, reduces infection, allows for minimal damage to the surrounding tissue, reduced swelling, pain, and very, very important is impressions can be made directly. Now, if lasers, erbium YAG and carbon dioxide, they are good lasers. The diode does not alter the implant surface. The erbium YAG also does not, but you have to control your settings. You have to use water. Similarly, with carbon dioxide, if you use a focused and a continuous mode, you damage your implant surface. So the carbon dioxide should be used in a defocused and pulsed mode. Well, both the lasers, they are reflected away from the implant surface, which is an added benefit. Well, the erbium YAG lasers also allows for detoxification, has a bactericidal effect, removes the biofilm, and allows for proliferation of fibroblasts. Well, the areas where laser is used in implantology is osteotomy site preparation, where you use a hard tissue laser. You cannot prepare an osteotomy site soft tissue laser. I'm sure you've understood. A soft tissue laser is used for soft tissues, but one area where a soft tissue laser is used is for dentinal. Hard tissue laser can be used for both. You can do depigmentation also with a hard tissue laser. You can do splenectomy. You can do operculectomy, everything. You can do desensitization as well. But a soft tissue laser is ideally indicated for all soft tissue procedures except for one area, only hard tissue, that is treatment of dentinal hypersensitivity. I'm sure it's very, very clear to everybody. Well, I was talking about the osteotomy site preparation. Secondly, decontamination of the socket, gingival contouring. Well, impressions can you appreciate bone loss on the radiograph? Exposed implant threads, you can appreciate buccal threads, threads which are exposed from the buccal side, the buccal area. Degranulation done with the diode laser, 980 nanometer diode laser was used here, 1.5 watt in continuous mode. DM bone graft was placed and thereafter it was sutured, and just see the results. This is at 6 months after treatment, and this is the preoperative. Wonderful results are achieved. Well, I would like to conclude my presentation with this American Academy of Periodontology Best Evidence Consensus Statement.
Thank you, Malika ma'am. I request all the online and offline delegates to stay tuned. We'll be shortly starting with our valedictory function.
Dr. Yash Sharma sir to felicitate our eminent chief guest Shri Chandmal Singhania sir and guest of honor Mr. Siddharth Soni sir. Now I would like to invite organizing team from Pacific Dental College and Hospital Udaipur. Aksha, Surabhi, Shweta. Please all come together one by one. Swasti, Diya, Niyati, Khushi Shah, Shweta Sharma, Arushi Agrawal, Shruti Agrawal and Shreya Bhartiya. Please all come together as we have a very less time. Now I would like to invite volunteers from Pacific Dental College and Hospital. Ricky Sharma, Ritik Kumar Singh, Shalom, Naresh, Dhairya, Nukum. Now I would like to invite Team CynoDent on the stage.
अक्षा भी रह गई, शालूम रह गया, शालूम भी रह गया, अक्षा भी रह गया, शालूम हम बाहर ले लेंगे।
Now I would like to invite our chief guest to add few words of wisdom.
मैं थोड़ा लेट आया, आपसे सबसे क्षमा प्रार्थी हूँ. आई एम वेरी सॉरी. इस संस्था ने मुझे बुलाया है. मैं इस संस्था के उज्जवल भविष्य और आप लोगों के अच्छे कामों को हमेशा अप्रिशिएट करूँगा. आप ऐसे ही समाज सेवा करते रहें और अगले नेक्स्ट प्रोग्राम में जब भी बुलाए मैं पूरा टाइम दूंगा. धन्यवाद.
Now I would like to invite Dr. Nitin Garg sir to declare the result of scientific presentation.
Good evening, everyone. I would like to start with poster. So third prize goes to Prakshi Somani. Dr. Anmol Dr. I would like to please welcome Dr. Vinayak to felicitate the winners. Dr. Lakshmi, please. So next prize for the poster slot goes to, that is the third prize, Ricky Sharma. Next is Amroz Ali Hassan. In the same category, the third prize goes to Khushi Srivastava. Next team is Khushi Shah and team, who have won the third prize in the poster category. Now coming on to the second prize for the poster category, the team that have won are Shwati Shib and team. Next is Nolly and team for the second prize. Divyani Gupta and team. Shweta Kumari and team. Next winners for the second prize for poster categories are Surbhi Namdev, Kumkum Rathor, Dharya and team. Next team who have won the second prize for poster category are Nupur Verma and team and Dr. Misbah Kadri and team. I request everyone to clap, please. Congratulations to all the winners. Now coming on to the first prize for the poster category. Any guesses? First prize goes to Bhavya Balchandani and team. Nupur Adicharya team. Nupur Verma. And the last team for the first prize in poster category is Debijit Mukherjee and team. I'd request all the participants to clap for the winners. Keep applauding for the winners, participants. Go everyone. Coming on to the next category for the scientific session, that was paper. The third prize goes to Surbhi Mahavar and team. The next winner for the third category is Dr. Anukriti and team for the paper presentation. The second prize for the paper category in this conference goes to Ashima Gupta and Dr. Ravindra Pratap Singh. In paper category, any guesses for first prizes? It's Swasti Jain and team.
बोलो तो जिसको भी सर्टिफिकेट्स नहीं मिले हैं आप सीट से उतर जाओ साइन करके सर्टिफिकेट्स.
I request all the participants and winners, if you haven't received your certificates on stage, you can contact the team CynoDent backstage, you will get your certificates. Don't worry about that. So first winner, so all the certificates are being arranged outside this room. There is a separate registration counter. You can collect all your participation and winning certificates from there. You don't need to panic about this if you haven't received your certificates on stage. So the first prize for paper presentation in the second CynoDent conference goes to Swasti Jain and team. Coming on to the category for the table clinic, we have the winners as Aksa, Anjali Daga and team, Vaishnavi Ahar and team, and last not the least, Sejal, Priyanka and Misbah. I would like to congratulate all the winners. All the participants keep applauding for the winners of table clinic. Now I would like to hand over to Dr. Misbah to proceed.
Now it's time for the inviting the winners of cultural activities. Riki Sharma, Darshita Mathur, Manasvi Jain, Dhairya, Falak, अनुश्रुति, भव्या, अनुश्रुति बैनर्जी, आस्था, दिया सिसोदिया, ऐश्वर्या, पलक, कृतिका कुक्कर, प्रियांशी मित्तल, विधि सोमनानी, कुमकुम राठौड़, विनाल कुमार, माही, खुशबू चौहान, कृतिका कुक्कर, अमरोज एहसान, ऐश्वर्या, हाँ मैम, मैं अभी उसके बाद ही करूँगी। दिया का है? दिया 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 तो यहाँ पे थे। नेशनल एंथम कौन प्ले करेगा? मैम मैम बड़ा वाला अवार्ड के लिए इनवाइट करो, बड़ा वाला। Now I would like to invite the interns of Pacific Dental College and Hospital on the stage. All the interns. Interns and volunteers from Pacific Dental College and Hospital. अक्षा, सुरभि, श्वेता, स्वाति, दिया, नियति, खुशी, श्वेता शर्मा, आरुषि अग्रवाल, श्रुति अग्रवाल, श्रेया, रिकी शर्मा, ऋतिक कुमार सिंह, शैलोम, नरेश, विनाल, धैर्य और नुकम। नेशनल एंथम प्ले करने के लिए Now I would like to invite Dr. Anmol Bagaria ma'am for thank you note. Before thank you note, I would like to invite Team CynoDent for felicitation.
नॅशनल अँथम तो नॅशनल अँथम प्ले करणार आहे का?
एक सेकंड लाइव चल रहा है, एक गाना बजवा दूंगी, ठीक है? मैं बजवा दूंगी, कल मना किया था आवाज करने के लिए, आज करवा दूंगी, ठीक है?
Good afternoon, everyone. I have a speech ready with me for the valedictory function, but I would just thank all the interns of Pacific Dental College and also all the volunteers and all the audience, online and offline, for their enthusiasm and also being our helping hand. Thank you for your love and support. We felt like home because of you all. And also all the CynoDent organizing committee, thank you everyone for being there always, and thank you everyone. I just made it very short. Thank you. And also special thanks to two people without whom I don't think this event was possible, and one without whom I don't think any event is possible, which is Dr. Ashish Chandra, and other person is Dr. Yash Sharma, without whom this event wouldn't have been possible. And obviously all the audience. We have two felicitations left for the camera person and also for the event person. Misbah, please. Then we'll start with the national anthem. Then we have a surprise for you all.
Now I would like to invite Dr. Ashish Chandra sir and Dr. Anmol Bagaria ma'am on the stage. And also Dr. Yash Sharma sir. All credit for this beautiful stage setup goes to Unique Event Planner. I would like to invite Team Unique Event Planner you on the stage. Himanshu and team. Congratulations. I would like to invite our camera person on the stage. I would like to invite our camera person on the stage. I request everybody to rise at your seat for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा। विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा। तव शुभ नामे जागे तव शुभ आशीष मांगे। गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे।